Hey, good morning, everyone. Hope you're all doing well today. It's wonderful to see everyone here today. And I know we have several people online as well, so we want to welcome you. My name is Julie Baldwin. I'm the Executive Director of the Center for Community Health and Engaged Research here at NAU. And we're just really happy to be able to host this event today, which is an ABRC workshop. As you can see, it's entitled Innovative and Career Ready Approaches to Enhancing the Behavioral Health Workforce in Arizona. So before we begin, we wanted to just give you a little bit of information about our center, actually. That's our welcome slide. And Nick's going to be talking here in a minute too about the AVRC program itself. So our center has actually been here for almost 10 years now, starting in 2016. We're really proud of the work everyone has done as part of the center. We've started as just a handful of people, about 5 people, grown to over 50 people now. And we've done multiple things, which I'm going to share with you about, but this is one of our favorite activities is the AVRC workshop series. So just before we begin, though, I think it's really important to do a land acknowledgement. And so Northern Arizona University sits at the base of San Francisco Peaks, or the homeland sacred to Native Americans throughout this region. And we honor their past, present, and future generations who have lived here for millennia and will forever call this place home. To tell you a little bit about our center, these are our mission and vision statements. Our mission is to collaborate with communities to build foundations and environments that support health and well-being. And our vision is to be a trusted partner and leader in research and action to attain the highest level of health for all people. As some of you may recall, we were originally called the Center for Health Equity Research, and some of our slides and materials still have that name, but we have evolved. We're now, as I mentioned, called the Center for Community Health and Engaged Research, but we continue to maintain the same vision, mission, and our values that we always have. This gives you an idea of the types of activities and really research priorities that we have as part of SHARE. We focus on chronic disease prevention and control, which includes cancer, diabetes, obesity prevention, infectious disease prevention, which includes COVID-19, HIV/AIDS, and STIs, maternal and child health, environmental health and indigenous country, and then of course behavioral health, which is the focus of today's meeting, on substance abuse prevention, mental health, suicide prevention. We've done some work in the area of oral health, especially in preventing early childhood caries and disabilities related work, and also in Alzheimer's disease and aging. This next slide is a little bit busy, so I apologize for that. But I think the main things I really want to highlight are kind of the different buckets of things that we do. So we have a number of large research grants, research center grants. One of them is called the Center for Native American Cancer Health Equity that Dr. Nikki Tufel-Schoen oversees. And then we have another one called the Southwest Health Engagement and Research Collaborative, or SHIRC. Some of you may have heard about SHIRC, and we have several people on our team that are part of SHIRC here today. But SHIRC really is focused on increasing and enhancing the capacity of our university to conduct biomedical, clinical, and behavioral research in collaboration with community partners. And we've been very fortunate to have that funding from the National Institute on Minority Health and Health Disparities for the last 9 years now. Oops, we got some audio. Oh, okay. Some of the other areas that we focus on, you can see here, are behavioral and social cultural areas, and I won't try to name all of them, but we have some wonderful colleagues in our center who are doing this work, like Dr. Sarah Sebo and others. And then on the right-hand side, you can see more about our community action work and education. And again, this is an area that we're very proud of and very passionate about. So this workshop series, along with a number of other types of coalitions and other types of community-based activities that we do, including public health workforce development and training. We have been very fortunate to have a number of students work with us. So over 240 students. And I just want to point out, Skylar Bordeaux, who's in the back there, was one of our Masters of Public Health students, and so was Michelle Cook, and I'm sure there might even be others here, that we have been fortunate to have as part of our center, who have then gone on to also become employees of our center too. And in terms of research funding, I think our team has been incredibly productive. 63 grants awarded, totaling $77 million over the last 9 years. So we have just a really amazing group, amazing team, and I'm so proud of them. In addition to these types of workshop series, we also have a number of certificate programs, graduate certificate programs, and other types of training opportunities too. And that's one of the things we want to focus on today. So in terms of the behavioral health focus, as part of the NAU Health Initiative, which I've been helping to lead over the last couple of years, one of the areas that we wanted to focus on was behavioral health. So we've been, again, really fortunate to be able to bring together a group called the Behavioral Health Advisory Committee. Dr. Teresa Birch has been one of the leaders of that committee. And we are so thrilled to be able to offer this workshop today. It's been a culmination of a number of activities that we've had over the last year or so. One of the first things we started with is doing an inventory of the behavioral health programs and mental health programs that we have on this campus at NAU. And you can see, look at all the departments and colleges that are involved. We have multiple programs at the undergraduate level, graduate level, and even higher types of training opportunities. So this is an area where, again, we hope our Behavioral Health Advisory Committee can really make a difference in terms of identifying where some of the needs and priorities are in the community for different types of training programs, whether they're degree programs or certificate programs, and then NAU can help develop some of those programs or strengthen and enhance the ones we already have. So this particular committee, as I mentioned, formed about a year ago, and it consists of a number of people at NAU, some of whom are here. If anybody's on the committee, can you raise your hand? Okay, I know a few of you are here today, and some of you might be on Zoom too. And it also consists of a number of community providers too. But if any of you are interested, I'll put a call out now. We'd love to have more members. And again, we're focusing on looking at our different programs. How can we ensure that they're really meeting the needs of our local community? So we've met with deans and chairs of the different colleges. We've worked with different department chairs as well. We developed a survey that we disseminated to the committee to assess some of the workforce needs. And we've hosted a couple of different meetings now at this point with our interest holders to share some of the survey results and solicit additional input from folks. And so this next slide just kind of illustrates the last meeting we had. We were able to put together a summary report. And these were some of the key areas of themes that were identified as part of this committee. So, and I won't go through all the details, but you can see here that soft skills are critical. So participants stressed the need for new professionals to possess strong communication, emotional intelligence, and self-care skills. Technology was a big theme that came out too, that it was essential. The committee identified competencies related to technology, specifically with fluency in electronic medical records and telehealth platforms. There was a lot of discussion about the clinical placement needs too, and how these need to be strategic. We talked about some of the potential solutions there. And then also the importance of the rural workforce that requires targeted support, specifically ensuring that we also draw upon the expertise of unlicensed behavioral health professionals too, and community health workers, community health representatives in our tribal community. So with that, I'll say thank you for now, and I'm going to turn it over to Nick. But before I do that, I do just want to thank all of the members of the Behavioral Health Advisory Committee who have contributed to this, and especially our planning committee. So I want to thank Dr. Teresa Birch, Dr. Natalie Randolph, raise your hand, Dr. Stephanie Babbitt, who couldn't be here today, Dr. Amy Armstrong, here today, Michelle Cook, and Christine Smith, who they might be still in the front. Nick, of course, and Melissa Griffin, who's our MC for the day, and she'll be coming on board shortly. So I'll turn it over to Nick.
Thanks, Julie. I wanted to thank our sponsor. We could not do these workshops without the Arizona Biomedical Research Center. Every year we host usually about 5 workshops with them. These are all free workshops, public health related. And every year it seems like we have got a new variety of topics, but we also continue kind of piggyback on topics from year to year. And so, for instance, our CCART addictions conference in April 10th, 11th, that's something we've done before. We've also done multiple workshops in beyond BMI and looking at BMI as a metric or as a bad metric, I should say. But yeah, these workshops usually span in the spring. And so I was a little surprised to get a couple in the fall. I'm always happy to get a couple in the fall. But we've got some great ones coming up. October 27th, we have a part 2 actually on March 3rd. But that one is titled, it's more of a CHR focus, but it's the science of CHR sustainability, advancing Medicaid and Medicare billing pathways. Their part 1 focused pretty much heavily on Medicaid billing. And so I think Sam was saying, Dr. Sam Sabo, she's organizing this workshop in March. They're going to follow up with a Medicare section. And so we'll have both those recorded and online eventually when they're completed. But that'll be a great follow-up in March. And in April, this one should be really interesting. I feel like AI is now in everything, as we all know. But we are doing an AI for Good, advancing care and improving lives. And so this is, we're working directly with Dr. Frank, I call him Dr. Frankie from Banner Health, Banner University Medical Center. And there's a lot of people doing some really cool things with AI. And so this is simply just a workshop to learn what they're doing, to see how maybe we might be able to implement it, but also kind of where are some of the missing gaps for research, potential research. April 10th and 11th, we're going down to, or I'm sorry, that's our CCART, our annual conference and reception. And I'm hoping this is not going to be the last year, but it could be our last year for these students. And so we're going to go out with a bang, have a great workshop. But these are incredible research projects. We're still trying to hash out what that workshop's going to be about, but culturally centered addictions research training. I think this will be our 3rd time we've done an addictions, culturally centered addictions workshop. So it should be really exciting. That'll be here on campus. And then April 14th, we're going down to Yuma. This will be our 8th annual conference with them on border health. And I just met with them yesterday, and it seems like the theme this year is going to be around strong border communities. And so in the past, we focus on increasing the healthcare workforce, but this year it seems like it's an important topic to talk about a strong, healthy border community. And so again, thanks to the Arizona Biomedical Research Center, and I will have some more at the end, especially for those seeking CEU credits. And so be patient and hang tight, and we will do that at the very end of the workshop. But I will turn things over to Melissa, and we will get our speakers on. Thanks so much for attending. We really appreciate you having here. Oh, I just wanted to say, these are some of the 3 outcomes. You probably have seen these on a flyer that we sent out. These are the same learning objectives. And so if we are successful today, hopefully we all will walk away with a little bit from each of these categories.
Okay, good morning, everyone. I have the pleasure of introducing our facilitator for our keynote speaker. Dr. Teresa Birch is a board-certified psychiatrist and the Chief Medical Officer, Chief Wellness Officer for the NARVA Institute and its 2 behavioral health accountable care organizations. She oversees medical strategy and quality for the NARVA Institute's affiliates and transformational activities, which includes the Arizona Public Psychiatry Academy, a telementoring program for physicians and APPs practicing in the Medicaid behavioral health system. Teresa has also been a community leader for NAU's Behavioral Health Advisory Committee that Julie just mentioned, and has been instrumental in helping plan today's event. Teresa will be facilitating our first session and introducing our keynote speaker. Welcome, Teresa.
Everybody, I'm so happy to be here, and I'm really happy to be able to represent the NARVA Institute, which is a nonprofit foundation here in Flagstaff that has quite a few different endeavors, including the Guidance Center, is one of our affiliates, and then we have 2 behavioral health animal care organizations, which cover all of the behavioral health community mental health agencies in Northern Arizona. So we are very interested in all the different things that NAU will be able to bring to Northern Arizona in terms of workforce development and educating the next leaders and clinicians that are going to be able to work within our system of care. And I'm really happy to be able to introduce my good friend and colleague, Dr. Sarah Bates Gibson, who is a psychiatrist, and she and I have been practicing together since 1992. We came to to the Guidance Center at the same time. And we're working together and have had the pleasure of working together, being good friends together, being next door neighbors together over all these years. And so you can see from Dr. Gibson's biography there that you will have a great time listening to her speak. So thank you, Dr.
All right. Evolutionary healthcare, wisdom, creativity, science, and tech. Kind of a long topic, and I apologize for that, but I also embrace that. Here is an example of stealing tech. This is Dr. Teresa Birch's slide that she made. And I want you to look at those baby faces up there and also look at imaging past elevation 13,000 feet. So this was 1994, a long time ago. I was nauseous. I could not breathe. And I was exhilarated. We had just gotten to the top of this amazing climb in Colorado that some of you may have heard about. And she drops this kind of bomb on me saying, hey, what would you think about being a pioneer in this new technology and way to deliver care and access to care, and we call it telemedicine. I'm like, what? I don't know what that is. And she said, nobody knows what that is. It's brand new, and we want you to pioneer it in the world. Actually, there was a guy in Australia doing it. So at the time, NARBA, Northern Arizona Regional Behavioral Health Authority, was tasked with overseeing all of Northern Arizona. This was 94, and we did not have the providers to provide access to care to our people. At the same time, we stole from NAU, Teresa did, that they had been evolving this distance learning model, which was brand new to everybody. Nobody ever heard of it. So she convinced me that I could do this. Now, why did I do such a crazy thing? I was a psychiatrist. I was seeing my patients. I was a little unhappy with having to bring my baby into the jail in the middle of the night because my husband was on call and I had a baby and I had to do a Title 36. But at the same time, I trusted her. We had been walking and hiking and training every Saturday morning. We've been talking, we've been connecting, we've been talking about our patients, talking about our families and our kids and all the things. And we had this connection, and I didn't hesitate. I just said, okay, I'll do that. So at the time, we were looking at how do we solve a lack of psychiatrists in rural Arizona? And the answer was telehealth. And this is a slide that I stole from her. Well, we did do it together, but we presented at a well-being conference. And we have evolved over the years to being this telemedicine program that's really active and provides care to all of Northern Arizona. What is important is that this is urgent now. It's always urgent, but we really feel an urgency now. Arizona ranks 47th. That's the bottom 3 for mental health treatment access in our country. Alaska's down there somewhere. Montana, where I'm from, and we're down there somewhere. But most of that, those mental health professionals are in rural areas, of course. So not only do our patients not have access to care, but our mental health professionals are tired, they're overwhelmed, they're facing burnout, they're disconnected. They got into this to help people, but they've lost their passion and their sense of purpose. Why am I here? Because I'm just tired. I can't do all this. And then we have these societal, this is the wrong, the PowerPoint, oh well. We do have these societal epidemics that we've all heard about. We have a mental health epidemic. We have a suicide epidemic. We have an opioid epidemic. So here's our model that I'm going to be talking about. Oh, I think I missed. Okay, so memorize this. But all the words that I put into my title are important, right? Evolutionary healthcare. Well, what do I mean by that? That's kind of a big ask. Wisdom. We don't talk about that very much in medicine anyway. Creativity, science, and tech. So this is going to be our model that, and really, I really only have 3 points today. One is return to our wisdom, return to our roots, and from that will blossom the creativity. My second point is connectivity, and that through connection and human connection, that's how we're going to make a difference with individuals and with society. And my third point is going to be that we go inside to our own personal self in order to evolve and help others. And we do that best in a group setting. So, well, so here's our roots. Here's our tree. We've got all these things that I call wisdom. We have lived experience. We have cultural competency. We have spiritual roots and wisdom. We have our professional experience, but we also have our personal lived experience. We have evidence-based learning, that we've done scientific studies and things evidence-based. And then we have our own personal self-actualization that we all call of our roots of wisdom. And from our roots, that is where our creativity can really evolve. And with that kind of care, we're looking for extraordinary outcomes. So let's return to our wisdom roots. Mentorship. We're going to talk a lot about that. That's very important. And that is the program that we started through the NARBA Institute and through Blue Cross Blue Shield of Arizona, where we do a telementoring program. But that's a group kind of mentorship, and there's also individual mentorship. Modeling by seasoned practitioners. We have a real difficult, especially when we're talking about career-ready professionals, meaning they're getting out there before they have a whole lot of experience or education. They're moving into the field. How do we train them for appropriate care? And I believe that modeling is extremely important. That's how I learned. That I still remember things from medical school, like earwax. Like nobody talks in medical school about earwax, but it's a big deal. It causes deafness. If you don't take care of it, it's uncomfortable. You can get ear infections, all the things. But I remember one ear, nose, and throat doctor saying, well, what you got to teach your patients is to stand under the shower and let that warm water go into your ear and sort of melt that wax. I remember that. That is modeling. And that's important. And it's deep. But it's not something that you're going to learn from a lecture, probably. And then a community of practice. And a community of practice is where you have multiple communities, multiple people together who are learning together. And there's a bunch of evidence about the importance of that I think might have dropped out of this slide. And then, of course, we grow with our science and knowledge, our personal growth, and our cultural humility. We'll talk about that with rural population. So here's my Venn diagram. By the way, part of this talk is about tech, and I was affectionately known for years as the teleshrink because I provided psychiatric care, and they just called me the shrink, and I was the telemedicine shrink. You'd think I would be comfortable with tech. I am not. Sorry, Nick, for this moment. But one of our fun games today is going to figure out where my decision to try a whole new type of AI for slide presentations did not go well. So we're going to find some really funny things, and it's going to be like a Where's Waldo. But here's my Venn diagram, which I am proud of. But down here we have foundational wisdom, we have human connection, and then on top we have our creativity and our science and our tech, all of those things. But right in the middle is evolutionary healthcare. How can we make our care, we're caring for people, but let it be evolutionary. So my next major point is connection. So competency, of course, we have to do competency. There are basic competencies that we need for this very, very important work. But that's not enough. We need connection as well, because healthcare is care. Here's my tree. And this is our second model of organizing and delivering care, is that we need competence, but we need connection. Can you find the funny thing that AI did to me? The twin pillars. How many twin pillars do you see? I see 3. Okay, AI, whatever. Okay, twin pillars. We have competence, like I just said, and those are learnable skills. That's like me lecturing to you. Okay, here's the meds. Okay, here's the, whatever I'm going to lecture to you about. And those are learnable skills, but we can also teach in other ways. And they're in education, they're practice, things we practice, they're skills that are learnable. And then there's connection. And that's what's so essential for health care, right? So this is where we talk about, we got into this to be a healer. We want to help people. We want to care for people. And that is not going to happen without a human connection. And this is a shared foundation. They both work alone. So I don't know why a foundation is a third pillar, but anyway. Okay. So this is a better picture. Thank you, Michael Van Ness from NAU. Competence and connection. So competence. Being a proud professional, being in a community of practice, these kind of competence things that we do. But then connection and trust. So when we're talking mental health issues, these are often chronic diseases, right? Like diabetes, like hypertension, like heart disease. These are all chronic diseases. And really, to treat a chronic disease, you need a relationship. There's a thing called the doctor-patient relationship. So we need to have a relationship. These are terms that we use now. Kindness. There's a whole literature around kindness. Isn't that beautiful? Lovely. Warmth. Those are, I didn't learn those in medical school. But those are proven to improve medical outcomes. Of course, this is my lens that I look through. And health span. And so what is health span? Health span is that you have a lifespan. Let's say you live to be 90 years, like my parents who are sitting back there. Thank you for coming. But what is a health span? Health span are those 90 years feel good? Are they healthy? Are they vigorous? Are they full of meaning? Or are they miserable because you are having medical problems and you feel terrible? So we talk about a health span over a lifespan. And of course, a kind human is always welcome. So for extraordinary outcomes, the patient must feel seen as an individual. And the patient also must feel heard as an individual. And this is how a professional can work on their connection skills. So things like eye contact, maintaining, explaining, this is why I'm scrolling here. This is why I'm typing. It's because, I have to do this, but I am listening to you and I'm making eye contact. And we have ways with our technology. I have a whole lecture on telemedicine and how to maintain eye contact while you're, talking. I have all kinds of things about that. We'll talk a little about that. But the patient also needs to feel heard. And this is so amazing. Listening is a superpower that we aren't always good at. I heard a speaker say, listen until the end of the sentence. So often we're thinking, well, somebody's talking, we're thinking, well, what am I going to say next? Where am I going? And in this realm, we really want to listen, and we want them to know that we are listening. We give the gift of our attention, and that is very healing. So, of course, I have this medical background, but also have a coaching background, and I've spent a lot of time developing coaching skills. And I would say the number one coaching skill that I learned was to shut up and listen. Because as a physician, I give advice, right? And I'm like, okay, take this medicine, oh, better get some better sleep, stop that drinking, whatever. I give advice. And that's not as effective in the models that we're talking about. Listen and find out what is motivating them. What are they interested in? What are their goals? And then don't just give advice. Ask them. You want advice? They might not want advice. Shut your mouth. Listen. And part of this as well is shutting your mouth, is listening. And I love the concept of the Jungian crone, the wise woman, the elder. She is the one who is like a boulder in the forest, strong, rooted. And the younger folks are having their problems, and of course they're terrible. But what she does is just put a hand on their shoulder. She's just there to put a hand on their shoulder, put a supportive hand on their back, and just be there. Give the gift of attention. Here's a great Dalai Lama, fairly revolutionary human. When you talk, you're only repeating what you already know. But when you listen, you may learn something new. And people will learn something new about themselves when they talk about themselves. And that's your job, is to shut up and listen. Okay, soft skill. Look at all this. We got to get all this done. We got to train all this stuff, right? It's like, oh, is this, establishment of safe, confidential spaces? Okay, yeah, do that. Stimulating self-awareness and exploration. Yeah, emotional intelligence, full engagement and presence with clients, all these things. Yes, we got to do all that. But the reason they're called soft skills is because they're more experiential, and they're more in the realm of modeling, and more groups, and we can train them. We can teach them. We can learn them, even if we're old. And that's where we have things like mentorship. That's where we have connection. That's where we have train the trainer. That's where we have groups. And I want to put out there that one of the most helpful places for people to learn is in a group setting. Because you're feeding off of each other, you're learning from each other in a deeper way that you're not always aware of. I got my dad out back there, and my dad has his doctorate in pastoral counseling, and he had an amazing ministry back in, what is it, 70s, Dad, or 80s, where he, in inner city Madison, Wisconsin, he had 100 to 200 people coming every Wednesday night in inner city Madison to do divorce group therapy. And they would all come in, and they would have a didactic, and then they would break up into little groups led by master's level therapists and volunteers from the community, and do this amazing ministry that people still come to him this day with the way how that revolutionized their life and changed them. So groups, and that's what is the amazing thing about community of practice for practitioners, is that group learning, being in a comfortable community where you learn together and you feed off of each other. And that's what Teresa and I had on our hikes. Over the years, that's evolved, where we have I don't know, anywhere from 3 to 12 women who just get in the forest and go hiking every Saturday morning. And one of my friends started calling it wise women walking. We, give advice about our kids. We would commiserate about our patients. And so much of what I have learned is based on those wise women walking, that community of learning that we've had. So what can we teach? Well, we can introduce group mentoring programs, mentoring guides as a group. We can foster peer learning, shared experiences, and that amplifies our skill development. So when we're having somebody present a case, other nurse practitioners in our group are going to say, oh, well, that's actually a lot like my patient. Oh, let's talk about that. Then we have that connection and that shared learning going on. And then, of course, we teach, but mostly we model psychological safety, a safe space, and that community. And in being a leader who is got humility, that nurtures that trust, that growth, and that spread. So this is my other stolen slide, because I couldn't figure out how to simplify it. 12 last night. Community of practice, efficient, scalable solution. It's got all this efficacy. It's got data. It's got here's the science. Here's the wisdom from which this practice is raising out of. And this is our public psychiatry certificate program that we're evolving into, and it's been just really fun. So, soft skills are vital. They can be taught. They can be modeled. They can be taught. They matter as much or more than technical information and knowledge, than those competent skills. Look at that. It's okay to make a mistake. Humility, curiosity are superpowers. Relationships underpin healing. So, paradigm shift. I was camping with my husband and my dog. 3 o'clock in the afternoon, late March. Snakes are out in the desert. I've seen them all over on the trail, and it was just warming up, so they were coming out, and I'd seen them. It was in the afternoon, and I had my Kindle. I was so excited I was going to go sit in my campsite and read for a minute. And I stepped over a parking block in the paid campsite. I felt a bzzz, and I heard a loud rattle. I elevated across the campsite, could not believe what had just happened, turned around, massive diamondback rattler. It just bit me twice. Oh, what? I can't even express how surprised and disbelieving. And then I started to panic, especially because my dog was standing right there. And they're both looking at me. I've got this snake, and big snake, and I've got my dog going, what are you doing? And I, flood of adrenaline, flood of fear, flood of everything. Called my husband. He was right there. And he said to me, Sarah, we're like, looking, what are you supposed to do? We're way out in the desert. What are you supposed to do for a rattlesnake bite? I can't remember. But he said, Sarah, the one thing that I see that you can do is stay calm. And I went, okay, I have a job. Okay, stay calm. I have a job. That was so important to me. I needed something to hold on to, and that was my job. Stay calm, stay calm, and then when I'd start to panic, I think, because if you think about it, you know, if you have a bunch of adrenaline, your heart rate goes up. Rushing up, and that's going to be more toxic, but I could stay calm. And then I'm in the emergency room, of course. It was an venomous bite. I'm fine. Everything was fine, but it's still a horrible situation. I'm in the ER, you know, I've got all this monitoring, all this stuff going on. I'm, you know, not trying to stay calm. And a friend of mine texted and said, she was actually camping with us. And after she knew that I was okay, I was. She said, wow, you've been inducted into the serpent family. You're in the snake family, and now you're transmuted. And then I started to see, oh, you know, that's the medical, they could do this, all the things. So what a way to change this terrifying experience into one of growth and change. What we got? Okay, so we need both a sense of purpose and professional competence for ourselves, for the professionals that we're training to be doing this work. But, and that includes a sense of personal fulfillment. What is the meaning behind this hard work that I'm doing? And for our patients, for our people, we need a professional competence towards that. Okay, great. Okay, so in order for us to be professionally competent, we need extraordinary outcomes for them. In order for us to keep working, we need a sense of fulfillment and a sense of purpose for ourselves. So how can I be of generative service? And what I mean by generative service is service that feeds me as well as who I'm serving. We grow together, we flow together, we both are evolving, we're both getting, well, evolutionary healthcare, right? What can energize me rather than deplete me? You know, I remember being in the office and just, oh, I've got this huge patient schedule and I've got all these patients to see. And I felt like I needed to hide, like I needed to conserve my time and to hoard my time and to hoard myself because people were trying to eat me up, use me up. How can that change to a sense of generative service that energizes, fulfills my purpose, fulfills my life? How can we do that? We're not servants. We're not here to be depleted by our work. We don't want, I'm working on this. My New Year's resolution was to take away the words "I'm too busy" from my life. Not going real well, but I'm working on it. And this is where the overwhelm and the burnout and the depletion comes from. And so how can we move out of that? So, I mean, you all have sat in the airplane and they say, put your oxygen on yourself first. I really think that's a hard concept. It's really counterintuitive and it's really important. So here I'm watering my tree. And what we're doing is we're empowering our inner resources for extraordinary outcomes. So first we empower ourselves so that we can do this work. And then for the people that we're serving, we empower their inner resources for their extraordinary outcomes. And I love this concept of give a gift. We'll talk about that in a minute. So we're back to our model, right? Here's our roots. And our roots, cultural wisdom, lived experience, professional experience, evidence-based learning, personal self-actualization. Ooh, I want that. And you know what? You can have that. And it's okay to do that first. From that base, that's why that's where the creativity can come from. See the brown stuff there around the roots? That's the compost. And I am sorry that my slide that I wrote about the compost didn't make it in, because I'm going to write a book called We Are the Compost. It was going to be a parenting book. I mean, that's all we are. We're just kind of that mucky little compost. We're a little stinky. We're a little brown and kind of rotting, but we're fertile. We're strong. And that is where the tree can get its nutrients and its richness and its strength, and can grow up into these trees. I'm a little obsessed with apples these days because there's apples all over Flagstaff. I got my parents an apple picker for their tree, and we have apples everywhere, and I love them. And those are our fruit. Those are our fruits, but they come out of the compost. And that is where the fruit of evolutionary care is, where we are going to come from. And that's where we're going to get our extraordinary outcomes. So, see the compost also be a ripple. This is not the right slide, so you can ignore it for a minute. You've all heard about the ripple becoming the tsunami. We have a friend who is a very, very good contractor, does very high-end houses, and he builds. And he was complaining to his wife, I can't find good workers. I can't find skilled, competent workers to help me build these gorgeous houses. And she, in her wisdom, said, that's because you have to train them. You can't just go out there looking. Remember that old apprenticeship? You need to own this problem and train these workers that you are looking for. You need to create them. And the same parallel process, my son was not doing so well at NAU. And so we were done with paying for that. And so he needed a job, but he was in construction management, and he is very talented with his hands, and he loves to work. And he's a smart kid. He just was lost. And in a parallel ripple, we happened to be watching Outlander with this friend, and mentioned that we had this son who was looking for work. And he took my son, embraced him, and the tsunami that came from that is unbelievable. I'll try not to weep, but he, every part of the construction business, what my son was taught. He was asked to go here, learn about this, here, learn about this, here, learn about this. And rather than just being the bottom of the totem pole and picking up nails, which is his previous job, he was learning and active, and he is a master. And when COVID hit, things sort of fell apart, but he came back to NAU and he got his construction management degree. It was a fabulous program. He was a seasoned practitioner of his art, and he was able to, and now he's in Denver and he's pursuing his passion, and it's beautiful. And it's all because of little ripples of coincidence and little pieces of wisdom. We don't have to do big things. We just have to be a small force of increasing the vibrational frequency of this world. So these are like evidence-based practices that we can teach. These are soft skills that are really have been found to be useful. Motivational interviewing, that is that piece that I talked about earlier when you listen, you be quiet, and you listen and find out what it is that your patient, I'm sorry to use that term, your client is motivated by. Because they are not going to, they don't want to hear your advice. They need to have an inner knowing of what it is that they really want. And that's what motivational interviewing is. That's a skill that we can teach. Access their own inner motivation. That's what motivational interviewing is. And it has to come from themselves. And that's why we listen, right? Involve their supports, their families, their culture, their roots. Find out what those are and let them be part of it. And this is my other great wisdom from the coaching world is curiosity, right? When you're really struggling with something and you're overwhelmed with emotion, so curiosity is a superpower, and curiosity can move you into new realm. Encourage them to find their own answer and give them a tool. So, I heard a lecture once by a psychiatrist who was in inner city LA, I believe. And she worked with the homeless in the street. This was a long time ago. And she said, you know, sometimes there's just nothing I can do. They're you know, I can give them some food. I don't even know if they're going to take their meds. I don't know what meds are going to help. It's just this quagmire. So what I do is I give them one gift that I can give them that they will always have, and that is a breath. Teach them one breath. And that is the one thing that I can give them that they can always have. And I love that. And I think that's so powerful. So let's do it. Let me give you a gift since you've devoted this hour to me. Thank you. Okay. Thank you, clock. If you're a Huberman groupie, you've heard about the physiologic sigh. And what that is a way to access your parasympathetic nervous system. But it's a little bit complicated, but you can do it. And it's actually really therapeutic. You can do 10, apparently if you do 3 of these, you'll knock out your anxiety. If you do 10, you'll go to sleep. I don't know. But what it is, it's an in-breath through your nose. Top it off. So you're really trying to feel alveoli, right? And then the sigh. The sigh. And the sigh can be audible if you have the courage to do that. Or it can be inaudible if you're shy. It can be a song. If you really want bonus points, you can hum. Got my Auntie Susie back there. She's a master singer. She can hum it. But even that might be a little complicated to tell somebody who's on the street. So you just take in a breath and let's let it out really slowly. That's all. Just one breath. Just one breath. And if you can keep doing that when you remember, just take a breath. That is a tool that is evidence-based, powerful, simple, and it can go everywhere. What I want to encourage is that we want to give the people that we're caring for a toolbox that they relate to. Remember motivational self-motivation, right? So what can they relate to? So, you know, I can remember talking about meditation and I can see my patient's eyes going, I'm not doing that. I can't sit still. I can't whatever. but maybe they can pray. Maybe they can take a breath. What is their culture? What is their experience? What is important to them? And how can you modify and go into their space and help them? So breath is a really easy and important tool that you can do. But there's many more. Tapping, I love tapping, and it's very simple, and you can go into very deep things with tapping, or you can just go like this. These little points on your sternum here that you can feel. I mean, it's kind of instinctive, right? You know, you're just kind of thinking, or you're nervous or something, and you just kind of put your hand there. You can do that in Walmart when you're having a panic attack and nobody will know. So, you know, find what you relate to and what helps you, and then you'll be able to teach it. So here's some of my favorite things. Movement. Who can work with an adolescent without taking them for a walk or playing basketball or something, like move their body? That it can be really super, super powerful is movement. And if that's something that you resonate with, then teach that. On the other hand, there's stillness. Be still. And that can be a superpower that they can remind themselves, be still. My husband said to me, be calm. And I could be calm. You can do sleep therapy. That's huge. You can teach them, I've got this app, it's free, and this is how I sleep at night. And I do that. And so you can teach them that. And you can do the thought model, CBT. This is, okay. Well, so it's reciprocal learning that we're talking about. When we teach, we learn. When we heal, we are healed. So first we do it and then we teach it, right? And that goes both ways. Oh, this is a picture of me. This is a treasure to me. Somebody drew this in a therapeutic relationship. And look at those roots. What? I'm so honored by this picture. And there's a little glow around the edges, like an aura. And the tree is reaching out. That's the kind of connection we want. We are the compost. I'm going to write that book. So this guy, I don't know if you can tell, here we have an AI snafu. That is a sandcastle, okay? So if your sandcastle is falling down, don't just keep adding on to the top of it. It's not going to work. Right? So if your sandcastle is not on stable ground, in order to fix it, you're going to have to take it down. And that is what a disruptor is. And we have disruptors every day, all the time, and they're terrible and they're horrible and we hate them and we don't want them. And what is a disruptor? A disruptor is a strong emotion. It's a tragedy, it's a trauma, it's tech, it's whatever. But that disruptor is an opportunity. A disruptor is a message to you to do something new, to look, to be curious, to stand back. It's not, and failure is commonly felt like, oh, I failed at this and I feel terrible about it. Well, you might feel terrible about it, but you can also be curious about it and say, wow, this is an opportunity. And there's a million wonderful quotes about overcoming failure. But yes, to opportunity. I am the compost, because compost is gross and stinky, but compost provides opportunity. This is a wonderful tool that you can give, and I'm going to stop in a couple minutes, so I'm not going to go into this, but unless you have questions. But this is the thought model that we use in coaching, but we also use it in cognitive behavioral therapy and evidence-based practice, and this is where you use a disruptor. And what I encourage you to do is when you have a bad, icky feeling, go, oh, hello, are you trying to give me an opportunity here? Good luck with that. I'm curious about you. And so use that feeling. It's a message to you that there's something that is an opportunity underneath that. And what we do in this model is we take the feeling and then we go backwards and we say, now what thought am I having that's giving me the feeling? And then you can take it apart, replace it with a different thought, and use those feelings as an opportunity for growth. So we have these societal epidemics, right? Mental health, suicide, overdoses. I'm big on the opioid epidemic. And so how can we do those? We're going to empower with proven efficacy, things that we know work. We're going to rise. We're going to be curious. We're going to be creative. And we're going to revision telemedicine as a means of connection. So this has been my wheelhouse for all these years. I've been doing telemedicine for 30 years. And what I want to really focus on here is that for technology to help you in competence, you can make it invisible and let it be a support. And so for telemed, what we really, and I have whole lectures on making the tech invisible. So, you zoom in to life size, you make sure the background is not upsetting, no beds in the background ever. But you work that you are looking at yourself before a session and seeing what's in your background so that you see what the patient's seeing, so that when you are actually seeing the patient or the person, you are just connecting and you're not thinking about the technology. And we were very successful in telehealth, in psychiatry, and in mental health. Patients would say all the time, I feel like I was in the same room with you. And I don't believe that that's because we had an amazing camera. I think that it's because we just worked to let that drop away and just worked on that connection. The same with AI. The EMR, you're just going to have to teach that ahead of time and practice with it and learn it because it can support us and it's getting better. But AI as well, they're there to decrease your cognitive load and support you, not to add to the complexity of what you're doing. And so use telehealth to support connection and bridge distances with your presence. Project Echo is a telementoring program that we do a lot, Tim. And at Health Choice, we have these communities of practice where we get together, all people all around the state, and we get together and we discuss cases and we teach about substance use disorders. We teach about what do we do with this patient who was traumatized as a child. So my proposal is that connection, when we're lacking when we're physically distant, if we add in telehealth, that's a social connection. So lacking social connection has been shown to be the equivalent of smoking 15 cigarettes a day. And that is one way that we can solve that. Remember that telehealth is also useful. It reduces stigma of mental health and substance use treatment, and it keeps people in treatment longer, which is really important in substance use treatment. So don't apologize. It's a wonderful modality, and we're doing everything we can to connect. There's all kinds of soft skills, and if anybody wants to talk about those, we can. Rural health, again, telehealth is one of our things, and I'm really excited to hear about the Alaska program. I think that's next. And so I'm going to let them talk about that. But what are we going to do to, and that was my whole thing. I was a practitioner in St. John's and Springerville, which were, it would be a 7-hour drive for me to go out there. Cultural humility. The places, if you're doing remote healing, you're going to be in a different culture than you are. So listen, pay attention, open your mouth, find out, learn from them, be curious, really be aware of how they're different than you. Are they different in their spirituality or their religion? How about their family support? Is it better, worse, different? Do they bring the whole family into a group? There's historic institutional distrust that's very strong in some of our native populations. All of these things are so important to be really sensitive to and just listen. Okay. My favorite quote, quality of care. This is Tara Sklar, who's with the Arizona Telemedicine Project. Expertise, ability, and therapeutic alliance are more important than proximity. So that's where tech is helping us, not hurting us. All these things, we need competence, we need connection, no matter what the technology is there. And that's our superpower. I'm not going to talk about that. So, oh, and oh yes, I do have my Yoda quote on there. Here I am, I'm Princess Leia. Cultivate willingness. Willingness, that's a really cool word, right? Willingness. Will in there, but there's also a giving, a willingness. Cultivate willingness to step in. Step in. Ask for willingness in your teams and the people you're training, the people you're mentoring. Yoda, do or do not, there is no try. So we're grounding into our foundational wisdom, into our roots. We're investing in mentoring, supportive communities of practice. Competence plus connection are critical to care. Be comfortable, be centered, be professional, period. This is the hardest job in the world. This is the funnest job in the world. Curiosity is a superpower. Teach your patients, but do it yourself. Take a deep breath and a prolonged exhale between every patient. Be grateful, look for joy. Look at that frog, man. Okay.
Maybe I have carried on these questions ahead of time because I'm not even doing them. So you talk a lot about using telehealth to connect with patients. You know, in the pandemic, a lot of people were from home. And in our rural communities, we have some behavioral health. We have a lot of physicians who think that that's about that they're just work from home. And they don't then have the opportunities to come into the clinic, bump into the nurse, bump into the medical assistant, other colleagues. What are the ideas about how people really working in those kinds of situations? Because you did that for them, but you also can do it works like this. How is it that you recognize people develop that creative connection to doing in their profession?
Well, again, I think the first step is to recognize that there is a need. Like if you're just doing your work and you're doing your thing, again, follow the disruptor, follow the feeling. Oh, I feel I feel so overwhelmed. Go into that, and then that is where the discovery happens. Hi, I'm really feeling alone and overwhelmed, and I'm panicking about this patient. We had our amazing Saturday morning hikes that were human connection, and that was a really huge thing. But I think that part of that responsibility is for us as leaders to be reaching out to and be the mentor and develop the community of practice. Because if you're just working hourly from your home and just trying to get your job done, it's hard to open up enough without doing personal development work and without getting to find that those connections and those mentors and those supervisors and those people who are going to give you that willingness you need. You're talking about so I think that's our job, is to also offer and be there and be a listen. What do you need? How can we help? Such as those of us who've been in the system.
And you guys talked about over the years, because we're not very minimized with the classes in the training, and
psychiatry, you know, pretty much all men, when you finish others, it's not that many, that's but what is your thought about that feeling of being imposter? When you want to use that, you mentors, and looking before your, you know, you actually people. That is,
Oh, yeah, sorry, forgot about that. Okay, we're talking about imposter syndrome, really. And this is an epidemic for our healers where it's fairly ubiquitous. I don't know that anybody doesn't have some sense of I'm not good enough, I'm not who everybody thinks I am, I'm not really worthy of doing this work. So it's a very vulnerable space, and it's frightening for us as individuals, and it's frightening for those of us in leadership. Like, how can we help? How can we reach out? And that's where all of these concepts of safe space and generating a field of humility as a leader that, no, I don't know it all either. And I'm searching, and how can I reach out and let you be, come into my space and know that it's okay. And then we'll do this together. When you're sitting alone in an office and you're having those feelings, I'm preaching to the leaders here, but we're all in the space as well. And so the more that we can disseminate that we're here in a safe place for all of us, and that's the power of the group. That's the power of the community of practice. And the more that we can create these spaces.
Okay. That was so wonderful. Thanks so much, Dr. Gibson. We really appreciate you sharing your expertise with us. I'm pleased to introduce our next session, which I'm super excited to hear more about. In this next section, we have 3 different speakers. They're going to share their experience working with behavioral health aid programs in each of their respective states. We have someone all the way from Alaska who will be sharing their experience with us. And we'll also be zooming in with someone from Oregon who will talk about their experience with BHA programs within tribal communities. And then we'll finish up with our very own Arizona representative to give us kind of an update on what is possible and what's currently happening within tribal communities and utilizing behavioral health aid models to expand access to behavioral health care in those communities. So let me introduce our guest speakers, and then they will each speak for about 15 to 20 minutes, which is so hard because I know they have so much to say, but we want them to kind of keep it short so that we can make it then more interactive and have a panel discussion where we'll also open up for questions from you all. So first up, we have Zio Owens. Dr. Zio Owens grew up in Wasilla, Alaska, and currently lives in Anchorage with her wife and their 5 children. Zio obtained her PhD in clinical community psychology from the University of Alaska, Anchorage. She completed her pre-doctoral internship as a clinician for the Yukon Kuskokwim Health Corporation, serving clients throughout the region. Since 2009, Zio has worked in the BHA program at the Alaska Native Tribal Health Consortium, supporting tribal partners' development and implementation of regional BHA programs and workforce. As the director of behavioral health aid training, Zio works alongside her team to design, develop, and deliver resources that support workforce training and development. In her time off, Zio enjoys being with her family, biking, cooking, doing puzzles, and playing games. Our second speaker will be Dolores Himerson, Master's of Social Work and licensed clinical social worker. Dolores resides in Washington and serves as the Behavioral Health Education Director for the Northwest Portland Area Indian Health Board with a focus on workforce development. This role includes directing the behavioral health aid program and serving on the Indian Country ECHO faculty. She's an advocate of nothing about us without us and the importance of growing our own to bring healing to tribal communities. Her passion for behavioral health comes from witnessing the impact of trauma and healing in her own family. Her 35-year career includes policy and administration, university instruction, clinical practice, national TA delivery, and serving on the Portland area CHAP certification board. Her clinical services always make room for spirit and the use of indigenous healing ways. Our third speaker will be Brooke Bender, who serves as the Senior Service Director and Community Health Worker Advocate for the Wallapai Tribe. Brooke Bender is an experienced Senior Services Director with 8 years of program management experience, including 4 years in director-level leadership. He specializes in revitalizing underperforming programs and guiding them into high-functioning, sustainable service models. His expertise spans the Community Health Representative and Worker Program, Women, Infants, and Children Program, Community Health Aid Program, Administration for Community Living, Title VI, ITCA, Title III, DES, SSBG, and multiple tribal and federal grant-funded initiatives. Brooke has a proven track record of developing and implementing policies and procedures, securing grant funding, meeting complex contractual deliverables, and successfully managing multi-program teams. He's a collaborative problem solver known for effective communication, strong community relationships, and has an ability to advocate for systems level improvements in tribal health and elder services. His work includes construction and home modification project oversight, strategic planning, community engagement, and partnership building with tribal, state, and federal entities. In addition to his leadership roles, Brooke has served in multiple advisory and committee positions, including the IHS CHAP Tribal Advisory Group from 2018 to 2024, contributing to statewide and national efforts to strengthen the CHR, CHW, and CHAP workforce. He's a contributor to several peer-reviewed publications, and Brooke has also been recognized for his leadership, receiving the AZ Chow Outstanding Supervisor of the Year Award and the CHR Summit 7 Prio Johnson Leadership Award. So let's give a round of applause for all of our speakers. And we'll welcome Dr. Owens as our first speaker.
Excellent. Give me just a moment to soak in the room, see who all's here, see these lovely faces. Thank you so much for welcoming me. Thank you for having some good weather so that I don't have to snow blow your driveway. Very grateful for that. You all might think that it's cold here, but it was 10 degrees when I left. So I'm roasting, but I put on a shirt, so a little layer, so it looks a little more professional right now. So before I actually get into my slides, a couple of things that I wanted to say about the behavioral health aid program. First and foremost, super excited. I have a lot of passion about this program, have been with it for a long time, have seen the impact that it has had and the services that it has brought to our most rural, remote, and often underserved communities in Alaska. And so it's exciting to see other people interested in the model and hoping to bring that to your communities as well. I have learned a lot over the years, and if I can do anything to help people reduce their hurdles and hoops that you got to jump through, I'm happy to share that information. The health aids, when you hear anyone talk about the health aid programs in Alaska, and there's 3 disciplines, I'll just be talking about the behavioral health side, but we also have community health aids, which is the medical arm, and dental health aids, which is the oral health arm. We describe them as the backbone of the tribal health system in Alaska. They are the front line of healthcare services in our rural and remote communities. They can be relatively complex programs. My job here today, I will tell you, my slides are a little bit text heavy, but that's really so that you can take a picture of them. Not because I'm going to read everything that's on the slides, but hopefully we'll have some more conversation afterwards. Couple of quick takeaways. It can be complex. It will take time, but it's totally achievable and it's totally worth it. I feel like we actually connected beforehand to coordinate this, but we didn't. But there were a lot of themes in the previous presentation that I think will move forward through our presentation today too. A bit of that has to do with connection. A lot of that has to do with really being willing to take a step forward and just connecting with people, having a good vision, and being persistent and determined, because it is definitely worth it, and just being curious. So without further ado, this is me and the BHA program. So this first slide, I'm actually just going to pull everything up here. I know time is going to fly by, and so I'm just going to put these up here. These are really the key things that I think are critical to understand and to know ahead of time and early in development with the behavioral health aid program, any health aid program. Infrastructure is critical. You can understand what are all the requirements for certification, what do you need to actually have the workforce, but if you don't have the infrastructure in place, if you don't have an understanding, not only within your behavioral health department, but within your entire health system about who behavioral health aides are and what they can do, what they can contribute, it's going to be much more challenging. So really investing in infrastructure upfront is just a good recommendation. BHAs, they are a workforce. It is also a certification program. And so understanding what those requirements are for certification upfront and really kind of integrating that into the entire time of their training and their practice is, again, going to help it to be very successful. In order to have a certification board or a certification program, you have to have a certification board. So when I talk about infrastructure, that's one of the things to really invest in with the infrastructure. As you heard in Brooke's bio, he's been really involved in the national effort with CHAP, and also in Dolores. Dolores's bio, she talks about being on the certification board for her area. I'll talk a little bit more about that in just a moment. But again, a really significant part of the infrastructure, invest in that early on to help with the success of the program down the road. Understanding the BHA scope of practice, it is a very specific provider type. And so understanding what all they can do, how they will fit naturally into your own healthcare system, it will vary state by state. And so really understanding what they can do, what they are trained in doing, and where you really want to focus their efforts. Training and education, this was also highlighted in the presentation just a moment ago. As you're developing a workforce, training is one of the biggest investments that you will have in that workforce. And so being really thoughtful about what that will look like. Again, all of these I will dive into a little bit more, but training is, when you look at the requirements for certification, training is one of the biggest components. And supervision. So I know we're talking about behavioral health aides here today, but BHAs could not be who they are and provide the work and provide the quality services they're providing without having a really good supervisor on their team. And one of the questions I have for you later actually has to do with telesupervision, because with most of our behavioral health aides, they are not located in the same community as their supervisors are. A typical presentation, which as I'm thinking about this now, I don't have it in my slide. A typical presentation from the health aid programs in Alaska will usually include a map of Alaska to scale on the lower 48. It's a really big state. And honestly, part of our state kind of stretches across the entire lower 48 continent. And so with our BHAs, they are most often located in our village communities, and their supervisors are in a hub community hundreds of miles away. So telehealth, telecommunication is really key for them to be able to do the work that they do. It's all about access to services. So just a quick history of the BHA program. It all actually started with the community health aid program, and with formal recognition in the 1960s, but my understanding is that there was actually a bit that happened before the 1960s. But ultimately, there were a lot of epidemics that were happening in our rural communities and limited access to care. And so community members were dying. The professionals who could provide the medical interventions for them were not coming as often as they needed. So you have local community members saying, teach me. I have lots of natural skills too. Teach me so that I can help keep my family, my friends, my community members alive until the next higher level professional comes. That was really the foundation of the health aid program. Really successful model. And so then in the 2000s, there was acknowledgement that there were a lot of oral healthcare issues that were going on. So they said, hey, use this model, develop a dental health aid program. So that's where the dental health aid program came. down the road, people were starting to recognize that we were having some issues related to behavioral health, suicide, domestic violence, substance use, a lot of it tied to colonization and historical traumas that many Alaska Native peoples and communities experienced. So again, we were given the guidance to use that model and develop the behavioral health aid program, which was formalized in 2009. I came on board to ANTHC in 2010, very soon after this program had been formalized. And it's been so exciting. It was a one team, speaking of growing your teams, one team deal back then. And now on my team at ANTHC, we've got 10 people. But our job at ANTHC is to serve all of the tribal health organizations across the state. And they are the ones who employ the behavioral health aides. So this is where we started. And this is where we are now. It's so lovely. You know, I think it's really important to put a face to the name, right? When we talk about behavioral health aides, these are many of our behavioral health aides that live in rural Alaska and serve throughout the state. We have an annual conference every year to bring them all in. Oftentimes BHAs are the only behavioral health provider in their community. And so it can feel really isolating. And so it's important for us to help them to see that they are actually a part of a much bigger system. They actually do have partners and colleagues around the state. And they are not alone in the work that they do. So we often describe BHAs as village-based counselors who provide culturally informed, community-based clinical services. They have taught me everything I know about the role that I'm in right now. So that sense of humility, I think, is really important. There's a lot that I've learned from them. It doesn't matter, you know, me having a PhD. I've used that degree to help kind of pave the way and knock down barriers for people, but it's really the BHAs who are doing the hard work. They're lovely. Unfortunately, side note, we did actually have to cancel this year's forum. I don't know if you all have been watching the news and you saw that we got hit by a typhoon. I saw some heads go, what? Check the news. The typhoon came up and it really devastated a number of our communities. We had big national responses, thankful for that, but communities where literally the majority of the community had to be rescued and removed from their community. It's totally devastated. They've been relocated to Anchorage, but where they were being temporarily housed was in the location where we usually hold our conference. So rightfully so, we canceled that, and a lot of effort has just been going into helping these people find a new norm because they will not be able to return back to their communities. So speaking of the need for behavioral health, our BHAs are also on the front line of responding to those individuals who have been completely displaced from their communities. So moving forward, again, just kind of trying to dive a little bit into those first boxes that I was talking about when we talk about infrastructure. It's important to see BHAs as a part of a whole system. So of course, I've got totem poles to kind of demonstrate that. And a couple of things related to that. Again, I'm not going to be reading all of the words on my slide here, but it's important, again, to understand the BHA scope of practice and to communicate that broadly, right? So regardless of the different type of provider you're working with, make sure that they understand the different roles as well as the limits of behavioral health aides. I think when people have come into the system and they've not been familiar with this new provider type, they might underutilize BHAs because they don't understand what all they can do, or they are trying to overutilize them. So really having a good firm grasp of what their scope is and communicating that across your provider types, across your health systems. Truly integrating BHAs into your healthcare system. So actively fold them into your workforce, which means including them in your treatment plans, talking to other providers about how you can work with them. What does a referral look like from the BHA or to the BHA? Working with the community members to understand who BHAs are. I mean, it's not every day that you welcome in a brand new provider type. And so there's some communication that has to go out about that. It's great when you have internal understanding of what that is, but if your community members don't know, then they might not seek that out, or they might not see them as a legitimate or professional provider that they can go to. And also, and this can and will take some time, but it is doable, but working with whomever it is in your state, whether it's Medicaid folks or other billable or billing or insurance providers, working with them to ensure that BHAs are recognized as a billable provider. Sustainability is something that should be in mind from the get-go when we're talking about infrastructure of these programs. Partnerships are the only way to make that happen. Connection, right? And that's not just tribal, non-tribal, state, Medicaid, insurance, education partners, just being really thoughtful about who you are working with to make sure that BHAs are truly a part of the system and not just off to the side. Last thing I'll say here, we really do have to work on, it's hard work, right? So if you think about BHAs, again, being on the front line, they are often the only provider in their community, behavioral health provider in their community. There's no us and them when it comes to BHAs. BHAs are members of the community, the same as the people that they're serving. And so when something happens in the community, they are equally affected. And so making sure that through their training, through their practice, their wellness is always being addressed. When we talk about supervision, that comes up as key, because oftentimes when we think about supervision, it's just, oh, I'm here to oversee the clinical case, but you also need to check in with the individual person if you want them to be able to stay and have some longevity there. So that shows up in conversations, very clear activities, but also in training. Why certification? This is a blanket toss, by the way. So it's traditionally and historically was used for people to get tossed up into the air and look out over the ocean and see where the whales were at. But I use that because we want to elevate the workforce, right? So again, just being able to help people see that this is a very legit and very trained up and very structured workforce. And so having certification, just like licensure, demonstrates that someone has certain competencies, knowledge, skills, abilities, and they've completed certain training and education. It communicates to other people that they have competence, and so that helps to bring respect to this workforce. It also supports with your billing efforts. And last, but certainly not least, it helps build the confidence of the BHAs themselves, right? So they themselves get to see that, like, oh, I am a qualified person to provide these services. And it also helps them to see where their path might go from there. This could be a stepping stone for some people to advance into, ideally, move on, and maybe they become the master's level clinician that's supervising BHAs in the future. But also some BHAs are really just fine and they do great work at just being a BHA. So moving into, I know this is moving really fast, but that's how it's gonna go. So moving into the certification board, I just have a quick description on the side of what the certification board is responsible for. But I also have up here bolded and italicized the standards and procedures, which is a document that everything that BHAs do, everything that our tribal health organizations do to manage a BHA program, it all stands on the standards and procedures. That document will detail, and it's available online, akchap.org. These are just some of the key areas within the standards and procedures that will give you more information about what needs to be in place to have a BHA program. So it'll detail what are the qualifications for the program and clinical oversight, eligibility, the scope of practice. There are different levels of supervision depending on what service a person is providing. So for example, if a BHA is responding to a crisis situation, they will have direct supervision, meaning they will connect with their supervisor as soon as possible about that situation, get guidance either before, during, and or after that situation. There are a number of requirements for certification. Again, training, it will detail all of the courses and the length of time, the objectives within those courses that need to be completed. It will detail who the approved training sponsors are or what it takes to become an approved training sponsor. Every level of BHA certification has a 100-hour practicum that is attached to it, so it will detail that. And then also there are certain work experience hours you have to achieve and competencies you have to demonstrate. All of those things must be in place before a person can apply for certification. But they've got, pretty detailed certification application forms that walk someone through all of that. And a summary of all of this stuff, again, can be found online. Oh, and continuing education, whoopsie. So in order to maintain your certification, just like with licensure, BHAs are required to complete continuing education, 40 hours of CEs within 2 years. This is a very quick summary. Again, not going to go through all the details here, but this is a quick summary of the BHA scope of practice. So BHAs can get certified at 4 different levels, BHA 1, 2, 3, and the 4th one is practitioner. They all build on themselves. So the expectation is that if you are working to be, or if you're going to be certified as a BHA 2, you also know how and have demonstrated the competencies to be able to do the services as a BHA 1. This, I often describe it as kind of working along the continuum of care. So BHA 1 level will often do some prevention, community-based prevention, early intervention, screenings, intakes. Crisis management is on there because ultimately, as soon as you get hired as a BHA, there will be some kind of a crisis that happens, and it's important to be prepared to respond to that. And then just orienting them to the actual field, giving them some basic skills about how to provide counseling services, how to connect with a person, how to stop talking, shut up, and listen, right? And how to, and motivational interviewing is also one of the key interventions that we teach early in BHA 1. And then we start to build on more as they advance. And so BHA 2, I'd say one of the biggest things that we're teaching folks is about substance use services. As a certified BHA 2, BHAs can provide a substance use assessment and treatment. And then it just continues again to advance. And we're teaching them about co-occurring disorders and then more details on how to work with children, the more advanced they get. This slide I will take a little bit more time on just because it is one of the biggest things that you'll invest in as you're developing a BHA program and workforce training, right? So a couple of things to keep in mind. We're adult learners. It's very different working with an adult learner than a child in elementary school. There's a lot going on in these brains. We have a lot of hats that we're wearing, a lot of competing demands for our time and our attention. And so when we teach people, we really want to focus on skills-based training, competencies, what is the need to know, and a little less of the nice to know. Give them, avenues to explore that as well, but we're really focused on what is the need to know to be effective in your work. And really developing critical thinking skills. So here's the foundation of knowledge that you need to have, and then how do you apply that in your work setting and in your unique community setting as well. It's really helpful to have different tools to complement their training. So I'll talk in a moment about the behavioral health aid manual. But when we're teaching, we also, there's a lot that people are taking in, but there's only so much that we can absorb at one time, right? And so it's helpful to have job aids or something that they can refer to later on that is just a quick go-to that summarizes a lot of the information they were presented with in their course. What is the process? Oh, for evaluation and remediation. So again, when it comes to supervision, but as well as our instructors when they are reviewing course materials, not everyone is going to pass a course first go round. So how are we going to address that? And one thing that we have with our BHA training center, for us, it's not good enough to just show up in the class and put your butt in a seat and then get credit for that. We want people to actually demonstrate that they have learned and that they have the ability to apply what they have learned in their work setting. So industry certificate and career opportunities. So I like giving credit where credit is due, right? So I don't think it's fair that someone's going to go through a whole bunch of BHA training, and then if they do decide that they want to go on and get their master's or their bachelor's and then master's, they have to start all over. So finding a way where possible and where it's appropriate to map the BHA requirements onto a pathway for them to move forward if that is what they choose. And it's critical. The learning doesn't just happen in the classroom. It needs to be applied into their work setting. So we're going to teach them a lot of things, but what does that look like in your unique work setting? All of our tribal health organizations operate differently. They all have their own policies and procedures. And the cultures across Alaska and Alaska Native people is very diverse. So what does what we're teaching you mean in your context? So a couple of things in the standards and procedures, it will detail, like I said before, the courses and the curriculum that is required for training. Something to think about as you are addressing training is it takes a long time to develop your own training center if that is something you want to do. It's also very meaningful because you get a little bit more ownership over how those trainings are delivered. So when we talk about, do you want to work with an established program that perhaps is attached to a college or a university, or do you want to develop your own? It's important that the training and the practice settings need to align. So it doesn't work as well if you send someone off to get training someplace and then you say, okay, now come and apply that in your work setting, if there's a disconnect between the training program and the work setting. If the training program doesn't know who a BHA is or what they do, the context they're working in, it's really hard for someone to take what they're learning and then figure out how to apply those concepts. So on-the-job training is really important, targeting the development of the competencies for an individual. So I guess one of the takeaways from this is, in my early training, I was taught about dual relationships. And I'm going to college in Anchorage, Alaska, which is our big city. And they're like, dual relationships, like you will never treat someone that you know, you will never provide services to someone that you have some prior connection to. And you teach that to a BHA and it's like, well, then no one is going to get services. Instead, when you have more ownership over developing that curriculum, you can say, actually, the fact of the matter is that you will see someone that you know or that knows you have some history together. How do you navigate that? Where are the hard lines that you draw? Like you're not gonna provide individual therapy to your mom. Sorry, mom. But you can connect with mom, say, figure out what the needs are and then get them connected to someone else, right? So it's more about, it's going to happen. How do you navigate it? That's a lot easier to teach when you have a little bit more ownership over the training program and understand the context of BHAs. Lots of different ways to provide training. Right now, our training center is primarily distance delivered. Many of our courses are asynchronous, meaning that people log in at a time that makes the most sense to them. We always have an instructor attached to the back end of those, so it feels very live to the students. But then there are some topics that really do need live instruction, and so we do offer those, whether it's a blended or it's an intensive, but they are live via Zoom, and then some courses are in person in our training center. Some people, learning via distance can be challenging. And I think someone was talking earlier, about technology. And so understanding where people are at with the technology, that's something to just be aware of. Supervision, the supervisor needs to know how to help the student apply their knowledge skills into their work setting. Again, not going to get into the BHA or the EBAM, but this is a resource that we have developed online. Again, BHAs, they can have this at the tip of their fingers. The 5 sections that are included in there is introduction, professional orientation. The client care topics is probably the biggest section that BHAs go through or access, and it gives a good foundation of very common behavioral health topics and walks someone through what do you need to know before you meet with your client. What are some questions that you want to ask maybe during, or symptoms you want to look for during the session? And then what do you do afterwards, whether it's documentation, follow-up, or referral, and or mandated reporting. Really great resource. And I believe this is my last slide. It has to do with supervision. Again, as much as it's important to invest in identifying a BHA who is a good fit for the position, it's really important to invest in finding a supervisor who is a good fit. So it's not just, I find often that someone is a great clinician, and so they get promoted into a supervisory role, but it's not the same thing. So making sure that a supervisor is trained in how to be a supervisor, it's important for them to have passion about workforce development, to be a subject matter expert, which includes understanding the BHA credentials, the standards and procedures, the scope, being familiar with the EBAM so that EBAM can also be a resource in their absence or distance. They need to have skills as a role model or a mentor, which was talked about a bit earlier too. A lot of that has to do with humility and being willing to learn from the people that you are working with too. BHAs, what they come to the table with is a lot that really cannot be taught in an academic setting. They have the traditional background, they have their cultural knowledge, they have the knowledge of their community members, the history of their communities. I can't teach that stuff, right? But that's really critical and makes it so that they can be most effective in the work that they are doing. You got to have skills for providing feedback, clear communication. Oftentimes BHA's English is their second language, which is a value added in the work that they are providing. Come to the table with a public health mindset. Please, rural and remote experience. It is a very different life experience living in rural and remote communities. So understanding that can be really important. And a lot of that has to do with community connection, right? You can't just go to the clinic and you're in your office and you just go home and you're like, that's it. You got to be connected to the community. Humility, willingness to learn. Just because you have a master's or PhD degree doesn't mean that you know it all, or that the skills you have will be the most effective in working with these community members. And again, investing in having ties to the community. So even if it's after work, go to a community event, just so that people see you as more than just the person in your office. And that, I think, will help contribute to longevity, but also keep people in their jobs for a bit longer. Yeah. So I think, oh yeah, that was my final slide. So I will pause there and turn it over. Do you want me to sit here? Okay.
Thanks so much, Dr. Owens. That was amazing to hear all the good work that's going on in Alaska. We're going to now transition to hear about the BHA program in Oregon. And I believe Dolores Himerson should be joining us via Zoom.
You should be seeing slides if it's working on your end for the BHA program in Portland. So let's all try to get ourselves grounded again after our little technical glitch. And hopefully you had some good humor. And listening to Dr. Owens, which you need to know, we have yet to meet each other in person. When I'm in person, she's online. Now she's in person and I'm online. So we got to make it happen. I've included slides. You could read more about this stuff later. We're going to try to stick to the more important stuff because I don't know how to work this. How do I go back? Okay. But I want to let you know who we are because Zio started to touch on something. The behavioral health aid program. All right. Now I'm getting feedback from somebody and I can't see chat, just so you know that. So Nick, I'll just need you to talk out loud or somebody else if I need to hear something or if there's something in chat. But I'm with the Northwest Portland Area Indian Health Board, and we've been around since the 70s, and we support the 43 tribes of Oregon, Idaho, and Washington. That's why I'm up here. I work remotely out of Washington. Why we're called the Portland area, it aligns with our IHS area. So the IHS area, that's where we're at. And we have mostly elected tribal leaders who sit as our delegates. I am a former delegate, even though I am not an elected tribal leader. Some tribes choose to pick other people to sit on the board. Often it's their health director. But why this is important, I want you to know that it was the tribal leaders. Every year they prioritize what they want us to focus on. So it's like I have 43 bosses is what it often feels like. And something they said over 10 years ago is we need to look at healthcare. We need to look at filling all these gaps because we do not have enough providers. We do not have people who are a good fit to serve our people. And out of that was a special acknowledgement of the number of people who were unable to access behavioral health services. We had people dying from suicide. And as many of us know, we also started to see methamphetamine. We were starting to see opioids. And so that was where this directive came from. And I want you to see, but we don't have the map like Zio could have. You know, we're 3 different states with all of these 43 tribes. But I just show this to you because these are the places that I'm driving to. Yeah, I have a lot of miles on my car. This is where all of our people are that we serve. And out of that, 10 years ago, we started to stand up our tribal community health provider program, which is focused on CHAP. We could not have done this if Alaska didn't. You know, it came about in Alaska after the TB epidemic. You know, so think about that for most of us. I think about behavioral health aids. It came about in my lifetime. That's also how old I am. But I share our logo with you because when you look at our T-chip logo, that is the one, the circle. And then when you look over at our totem poles, you can also see our website, tchip.org. That was down for a while. There's some stuff happened in January. This country had a new administrator. I know this is being recorded, but I'm still saying it. We had to protect ourselves and our federal funding. So those sites were pulled down for a while. They were made private. Our tchip.org just got up in the last 2 weeks. So you are free to look at that even now while I'm talking, because it gets boring listening to me and looking at slides. But I want you to see the logo because it represents all of our CHAP disciplines. You have your dental at the top, behavioral health, and the bottom one is our medical. That's our community health aid program, which is just being stood up. So they're just going to start getting their training going. Dental's been around for a while. We have our totem poles, our raven and our thunderbird. I probably got those wrong. I always mix those up. They protect us. They watch over us. And more on the disciplines. All these slides are going to be available to you. We put the community health representative in here because we developed a community health representative training in tribal communities. Community health representatives are those frontline workers, often transporting. They're the ones in the home. You often see them at the health fairs. They're out there doing the A1C finger pricks. They're checking your blood pressure. All those good things. They are from the community. They know the people in the community. They know what's going on, who everybody's related to. So we developed a training. It was totally online. But what we were doing with that is getting our, as Eo said, the adult learners, getting people oriented to that learning, kind of getting that rhythm. And we were presenting on our different CHAP disciplines. And what we were noticing is people wanted to enter into our programs from there. So we have several people that have entered our behavioral health aid program from CHR training. You've heard about what behavioral health aids are. A lot of what I'm going to be talking about is our lessons learned. I'm going to be talking about our training program. I'm going to be talking fast at times because I want to try to give you mainly the lessons learned, some of those nuggets. Again, you can read the slides later because we want to leave time for you to be able to ask questions. Something that I want to emphasize is the importance of our behavioral health aid training as well as student support. If you are going to develop a behavioral health aid training program, you truly must have student support. And the requirements, just as the Alaska area, CHAP, they have their certification board and standards. We have our Portland area standards and procedures. You can get those through our website. What you're going to find is Alaska was our mentor. When we were dreaming up this idea to stand this up, we really collaborated. We learned from Alaska. They've been doing it a long time. They're developmentally ahead of the rest of us. So through that, what you're going to see is when you're designing your training programs, it really needs to have providers. You need to have people with the experience. You need to have those behavioral health professionals. If you're going to be training online, it really makes a difference when you know how to do that coursework, distance learning. We started out with 2 different programs. So with our training program right now, we have Northwest Indian College. You have some pictures up there from our graduation, our first graduation. That's those pictures there. So the 4 students at the top that are blanketed. They were from Heritage University. They continue to work. I just heard from their supervisor. There's some continuing education they're requesting. And then you have our first graduates from Northwest Indian College in that bottom picture who were blanketed. So we also want you to see the faces of the people from our tribal communities. But I'm going to share something that we learned, because keep in mind that we started CHAP, in 2015, thinking it through. It was in 2018 that the Northwest Portland Area Indian Health Board came to us over there at the Confederated Tribes of the Umatilla Indian Reservation, where I was that mental health clinical director. And they said, oh, we have this great idea. Alaska's doing this behavioral health aid program, and they go out to the villages. They're going on and on. I'm this person who is very skeptical, and I'm just like, well, why would we do this here? We're not villages. You got to tell me why this is so unique. And anyone who knows me, I'm this person who digs my heels in. I want to make sure I have all the information. I want to protect the people. I'm this tribal person who's all about systems change because of things that I've experienced in my lifetime. You take your lived experience that motivates you to create systems change policies, advocate for all these changes. But where they hooked me in is they said, think of it as like on the job training. And we're going to have people from the community, how we recognize those people have those certain skills. And we think, oh, they'd be really great to be part of the behavioral health team. Then they started to get my attention. And then they said, we're going to train them. They're going to have hands-on practice, they'll have clinical supervision throughout the way. And if they only want to become a level 1, they can stop there. We're designing it in such a way so if they want to go on and become a practitioner, so they'd be similar to you as a master's level clinician, they could do that. But the biggest thing that got me is when they said it's culturally relevant. We're going to design a program so we can tease out what makes it different. We can tease out the need to address some of those things like dual relationships. I was listening to our keynote speaker and I was getting excited, wishing I was there, because it's like, oh my gosh, she's describing cultural safety. She's talking about all the stuff that we know makes us tribal, and what makes us different is that relational worldview. We need to have connection. We need to have balance. So they hooked me in. I have been part of, before we had academic review committees, I was one of the community advisors as a provider. You have people from the community. You have people who were providers. You had your tribal leaders. Why I keep bringing this up, there's all these parallel things going on at the same time as you're standing up a program. You heard about the infrastructure. We couldn't have this until we had this directive from our tribes, those delegates who said, this is what we want. So we knew that they wanted it. We knew based on our epicenter data, based on data from our communities, when we were looking at penetration rates, there was an access issues. Then we were looking at how come sometimes when there's behavioral health services available, our community members aren't accessing it. And oftentimes what we were hearing is we have people who don't fit, I don't feel comfortable. I don't feel safe. All these reasons like that. So again, that was supporting, all right, let's continue to move forward with this. And then it's very expensive to do this. So HRSA had funding, the Opioid Impacted Family Support Grant. You're thinking opioid impacted, and this is a behavioral health aid program. Well, that's what we said. How can we support families? Because the opioid epidemic, fentanyl, meth, those things were impacting our families to the extent that, it was in 2023, we had the National Tribal Opioid Summit where tribes from all over the country, people from DC and places like that came together. And what we heard there as well is we need people who get it, people from the communities. So a lesson we learned here, we had two training programs. One was in person, Heritage University. You had a very charismatic leader who was part of this visionings. She entered the same time I did. She was part of the community advisory group. A lesson learned is when you have a charismatic leader who suddenly leaves. You know, it's like, oh, you lose this person who was your boots on the ground. She was keeping everybody together. She was keeping the ball in play so we can continue to recruit and grow this. What happens when that person isn't there anymore? What happens when you suddenly have a new provost, when you suddenly have a new university president and they have never heard of the Northwest Portland Area Indian Health Board? They don't know what the BHA program is, and they don't even know any of this. I'll tell you what happens is they issued a moratorium, a 1-year moratorium, because the person who was left as their behavioral health aid coordinator is on sabbatical. So it's suddenly like aliens abducted everybody. So that program is currently on moratorium. I'm sharing all that. These are lessons learned the hard way. And included in that is we're doing continuous quality improvement. So we're also learning that in-person learning, when your university is located in a territory that serves mostly one tribe, it was difficult because we have people, you saw the maps, people from all over, as well as we have people from Oklahoma, Montana, South Dakota. Is very difficult to travel in for classes every weekend. So lessons learned. Then we have on the other end of the spectrum, Northwest Indian College. It's a tribal college. Think about the map in Canada. They are close to Bellingham, Washington. They are close to British Columbia. They are a college, Lummi Nation, Lummi territory. They have been around forever. And I always say I wish there was a school like that back when I was going to school in the 80s, because I would have loved a school where you're learning in a relational way. So again, something you can look up is Terry Cross's relational worldview model. He was the founder of the National Indian Child Welfare Association. But when you have a relational approach to course delivery and even how you form it, that makes a big difference. So at NWIC, we have a 2-year program where you get that associate's degree as a behavioral health aide. You are learning all those core courses. You graduate with all of the requirements so you can apply to be a level 2 behavioral health aide. Something that is always very exciting for me is to go in June, the month they graduate. 2 days before they graduate, all the students are on campus and they are presenting their research. So those BHAs pick something. They do research and evaluation over their 2 years, and their final research is presented those couple days before they graduate. They're looking at things like plant medicine. They're looking at things like when you include cultural ways of knowing into service delivery, the impact it has for clients. There's more pictures of NWIC. It's beautiful up there. And educational sovereignty, we currently have over 70 enrolled students. We are currently recruiting for our 6th cohort. Our 6th cohort is going to start on January 5th. And it's a culturally unique program, as I said, but what makes it unique is the focus on tribal sovereignty, holistic healing. We acknowledge the impact of colonization. We look at historical trauma. We don't lead with our trauma, but it becomes part of that understanding and acknowledgement. The courses are delivered by tribal people. One of the lessons we learned, I think I'm going to have it on another slide. So I don't even remember my slides, but clinical supervisors are able to come and sit in a course if they want. Oftentimes they do. And what they get in turn are those CEUs for their license, for their certification, but then they're able to experience what the BHAs are learning. Because I'll tell you what, there's a lot of behavioral health providers who were skeptical, like I was. And they're like, what do you mean? They're just going to go for 2 years, then we're going to have them here. And then they had questions like, how are they different from peer delivered services? You know, how is this different from a certified alcohol drug counselors? Those were questions that clinical supervisors and health directors had. But we do this holistic model. We focus on being a good relative, knowing that everything has life. It's not just about the human factor. And included in that, in being a good relative, is realizing that in tribal communities, in our families, there's a lot going on. You heard Dr. Owen say we have adult learners. You have people who are working, raising families, they're part of extended families. We have folks who are dealing with their own autoimmune disorders. They have family members navigating cancer, serious illness, you know, suddenly there's a car wreck. Students often think that they have to leave school because something's happened and they need to go help support family. Something we've built into our program is normalizing stepping out when you need to take care of yourself, but also coaching. I love that, again, our keynote talked about coaching. We offer coaching in transitioning from being community member to being a professional. And what does that look like? And a big part of that is communicating. We got to communicate with our supervisor. We got to have a plan in place. We call it that safety plan because we know something's going to happen somewhere along the line. So when you're graduated as well as while you're in school, normalizing how to advocate for when you need a timeout, and then communicating with us at the board, communicating with their instructors. So we know that you're going to come back. Part of our student support includes us checking on you while you're stepped out, just seeing how things are going, because we don't want to lose you. That's part of our retention. Certification can't happen without a certification board or clinical supervisors. Again, that image of the structure. The Portland Area CHAP Certification Board, we didn't have authority until last year at this time from the then IHS director. So we could certify CHAP providers. We still can't certify all of the CHAP levels. Our practitioner level, think of that as level 4, they get certified through Alaska. Before we could do this, we had people graduating before we had authority to certify. What did that mean? Our providers had to be certified through Alaska. What does that also mean? All of our coursework, you know, our curricula, we had to send it through our academic review committee. We have a BARC. We love acronyms. We have DARC, BARC, and CHARC. So with that, our academic review committee looked at the curricula from both training institutes. We aligned it with our standards and procedures. We looked at hours, topics, seeing if it was meeting everything. Once we said it does, we sent it to the certification board recommending the curriculum. Once that certification board looked at it, they had to send it to the Portland area director, who then sent it up to Alaska. And then Alaska had to decide with their certification board if it met the criteria. So I just share all of that. So as these other places that are going to stand up their certification boards and their BHA training programs, those are things to think about. Lessons we also learned was from clinical supervisors. They were familiar with state licensure. They did not understand what it meant for sovereign certification. And that's what the Portland Area CHAP Certification Board is. So we were doing social marketing and educating clinical supervisors. We were inviting them in to be part of the process. And we continue to stay connected with them through that quality improvement, as well as finding out what are some of the, continuing education needs. And with behavioral health aides, all of this was new to them as well. They're like, what? So helping them to understand how to create a portfolio, how to apply for certification, what that looks like, what it means. In continuing education, you already heard that, it has to be 40 hours every 2 years. One of the ways we also do that is through our Indian Country Echoes. We created an echo when the behavioral health aid program started. It's the Northwest Elders and Knowledge Keepers. That's the first Tuesday at every month at noon Pacific time. If anybody ever wants to come to it, it was an opportunity for our behavioral health aid students to begin to practice what does it mean to get case consultation. But when your case consultation is coming from a panel of elders and knowledge keepers, as well as those who were tribal providers that have been working in the system for a while, so you can learn from them and get consultation. That's how it started. We're so glad that we're now able to offer those continuing education hours through IHS, but we included CHAP providers because they were missing from the equation before for those hours that you could earn there. And I'm talking really fast so we could get through that. And I'm going to stop sharing, but that's everything for now because I know we're going to come to questions. And now back to you in the room.
And next up, we have Brooke Bender to talk about the experience of using the behavioral health aid model right here in Arizona. And if you all are following along with our agenda, you'll see that as we expected, we're a little bit behind schedule. So we're hoping that you all might be okay with us extending this part of our conversation, maybe 10 or so minutes, and going to lunch a little bit later. Is that okay with everyone? Okay, wonderful. Please welcome Brooke.
I never come with slides. You get me. I'm one of those people that never prepares, but always just comes up and kind of take it by moments. If you would take that down, I don't like people looking at that, please. I don't like looking at my own accomplishments. So I'm Brooke Bender, and I do have a disclosure that I'm here in my own personal capacity. I know I work for the Wallapai Tribe, but today is my day off. So you get me again. So the background for the Wallapai Tribe. So working in Arizona, there has been no formal behavioral health aid program. Right now, it's just a concept, but the Wallapai Tribe has done a workforce assessment on this. And the idea that we had come up with was trying to work with the Portland area, because I had been in this workforce for the last, since 2018, and I served as the Indian Health IHS Phoenix area representative on the chat tag, and I served as the chair, co-chair for in that board. And they disbanded in 2014, and they established the National Community Health Aid Certification Board, which operates from headquarters in IHS. And if you are familiar with IHS, IHS has one big office in DC, and then they have 12 different regions or service areas. And Phoenix area is this one here, which encompasses Nevada and Utah. There is one tribe that they do take in under their service unit, which is basically in California. So there's in that corner too. So the background on that portion is that for Arizona, they didn't have any, but there is a need for it. And a while ago, they did try to formulate the idea with the Navajo area. They did apply for the grants that were being provided by Indian Health Service, but it was hard for them to get it off the ground. They couldn't really get further into just idea. They were granted the funding. So after they kind of, I do words, after they actually realized that they couldn't do the workforce assessment and have idea to get it off, they provided the money back to IHS, and that got redistributed. So after being on the board since 2018, I decided last year when we had a CDC grant, the CCR grant, with Arizona Advisory Council on Indian Healthcare, it was offered for CHWs and CHR workforce. And I had this idea off of Portland area was to do a workforce assessment for community health representatives and see if there was a willingness or at least wanting to advance their careers as into like a provider type. And it was actually really well received. We identified in that workforce that yes, there was acceptance and there was willingness to want to advance, because working in the CHR and CHW workforce area and advocating for their workforce needs, we found that there was a ceiling for them and they really didn't have nowhere else to go. They got their training. They were there for, some people there for 44 years, but they've never really went beyond becoming a community health aide. And what has been happening in the state here is that some tribes are actually looking out to advance them into becoming community, not community health, what do you call that, the CNAs? Are some of them becoming LPNs, and then some of them moving into being nurses. But it takes them outside of the community capacity or community work experience. When you become a clinical type of provider, you're becoming more stuck into the four walls that are established. And so we want to take healthcare back into the community because that's what you're hearing when people are having issues with healthcare is that I want somebody to come to me. I want somebody to have my lived experience. I want somebody to understand where I'm coming from. And the way I always look at it from my own personal experience is that when you go into a clinical provider setting, you see the patient and you see it in a sterile environment. You get 15 minutes with that provider. They're only seeing the one complaint, your chief complaint, and they're not really understanding the multitude of factors that are happening. So what's happening in the environment of the home? What is the nutrition intake? Are they actually taking their medication? When you do a home visit, you actually have that glimpse of what's happening. So as a community health representative, and I was one for about 8 years, I used the example of going in to see a patient that had diabetes, walking in and she's telling the provider that I'm very compliant with my medication regimen. I'm doing what I need to do. But when you walk into the home, you're like, there's the vitamins there that you're supposed to take. It was like you're losing a lot of vitamins when they're doing the dialysis and removing all the fluid off of you and replacing it. You need these vitamins to help, keep you strong, healthy. They're not taking any of it. You're looking at the refrigerator and you're looking at the dietary things that they're eating. It's not healthy food. It's not nutrition. It's more soda, high starchy foods is what they're eating. Mainly, they're not really compliant at all. When you're looking at a dialysis patient, it's like there's a limitation on what fluids they can have within that period. They're not compliant with that. So I say that is that because it's a sterile environment, they don't get a full glimpse. But if you actually have a community health aide that actually is doing the home visit, they can see exactly what's happening in the home. And they can actually tailor the treatment or at least a plan to that specific person. Because when you go into a clinic, you're hearing what they want you to hear. They won't tell you what you want to hear. They're not telling you what's actually going on because they're scared. They're scared to go to the hospital. They don't want to be transferred out somewhere. So you're not actually getting that full opportunity to treat them. So we did a workforce assessment. So with all that said, so we did a workforce assessment recently. And so that came back is that they did want community health aides, that they did want behavioral health aides. And in the capacity for community health aides, they wanted it to be served for elders. That's the main population that they wanted to address. And then there was for the behavioral health, they wanted youth because youth have a high rate of suicide or suicide ideations, and there's no treatment there. But in the capacity here for Arizona, we found that, yes, it is hard to find these providers that are actually certified, that can meet the requirements, education requirements in rural communities. And the one community I always highlight is the Havasupai tribe. They are very rural. They have a hard time getting providers to even go in. And the IHS setup is 2 weeks in, 2 weeks out. So a provider goes in for 2 weeks and then they end up coming back out for 2 weeks. And then there's another person that goes in. So the consistency for providers is really non-existent because they leave and there is different requirements for them. And so you're having workers that work in that type of rural capacity having to dual multiple hats. They're being a social worker, case manager, behavioral health, or counselor. So we find that tribes want somebody that reflects them or mirrors who they are from their community so they understand where they're coming from. So that's my idea was here. So, and from my learning and my experience working with the Alaska tribe, serving on the board, and then working with Portland area and listening to their specialists and expertise in that area and trying to figure out how do we get this moving forward in Arizona. So that was my idea, was to utilize the grant that we had to do a workforce assessment for CHRs to CHAs. The findings were there. What has been done currently right now is that we are in the final assessments, and what we're trying to do right now is find educational partners. We identified 2 areas that we wanted to work with, which was NAU was one of them. And then we wanted to work with a community college. We're trying to do region. And that's what we're looking at, regional up in the northern Arizona. So that's kind of like we're in the infancy stages of that. So we did have a conversation, but it's mainly looking at your programs to establish what you do have, because we don't want to recreate the wheel. We also want to work with Alaska and kind of mirror their type of programming as well as Portland area, because they're the two. They're who we have to work with, and working with IHS National Certification Board is that they like to stick with Alaska's model, and Alaska's model is very important because they are the ones that have created this whole thing. They laid the groundwork for all of this. Portland had to mirror off of them as well and utilize their scope of practice. And so that's what we also have to do. But there are challenges in that. There is challenges with that, is that if you go with Alaska, there is a emergency services type of training that is required with them, because they're so rural that they don't have emergency services. So it has to be baked into their scope of work that they need to be able to respond to emergencies. They need to be able to address them in that moment. You don't have time for EMS because EMS isn't there. It's like, it doesn't exist. So you are basically that emergency service. And Portland area did find that is one of their challenges, is that they don't find that emergency training to be a requirement for them, but they are held to that standard still. I know that that's something that they're working. So I would hesitate to keep that in, because we also don't have that issue. We have emergency services that can be to us within like 3 minutes, 5 minutes. It doesn't take them an hour, 2 hours. So that's what I would say is a challenge for the Northwest Portland area for Arizona. When we are working towards these goals, I would say that what we're looking to do is establish an education program. We want to establish the partners, because we need partners to do this. The other things, the next steps I would say that we're going to have to do is finding funding, because funding is very important. There is a challenge utilizing federal funding, is that when you're working with IHS, not to divulge anybody else's, but IHS does have a tendency to override your authority to use that money. They dictate how you're going to utilize that funding, and it pigeonholes the tribe and also the institutions and programming from moving forward. So staying out of the hairs of IHS's funding is very important. So these are the lessons learned from Alaska, also Oklahoma, because Oklahoma has found themselves in that same type of issue with the funding and IHS really holding them out. So I find that Arizona does have a lot of capacity. So they do have the, what do you call it? The Jeff, I can't remember his name. It's the education, AHEX. Yeah, so Arizona has AHEX. They have funding for training. It just needs to be requested, work with them to figure out what they can do and what they can't do. Applying for grants would actually be really helpful for institutions to help apply for grants, but and then the other areas, the academic review committee, and also formalizing a partnership with Portland area, because Phoenix is not anywhere near that. But what we can do is request those in the circular that was established, that the Phoenix area tribes just need to formally request from the area director to establish a certification board, academic review committee. But because we're not in the place right now, we can actually make a request to formal agreement and ask Northwest Portland to be the certificating body for the workforce. So that's awesome. I'm like, don't put that back up, please. So that's where we're at with the Phoenix area, but we're in the infancy stages. But I am taking the lessons learned from other areas and trying to make sure that we don't follow 100% of those footsteps. But your partnership is actually good, because we need to be able to address tribal communities and rural communities and getting healthcare workforces in their communities. People don't want to come to rural communities. It's the shopping area. So we're not that rural. I can tell you that we're not that rural. the nearest community for us is Kingman. We're 45 minutes away from the nearest shopping center, but people want to be in Vegas. But I also don't think that that's that too far away, because you can drive from Peach Springs to Vegas within 2 hours. It's not that far, but that's a barrier for people to come in and work in tribal communities, and housing is limited as well. So it's like those are your type of things, and finding that workforce, those supervisors that are willing to work and think outside the box, because they think about state licensures, and these aren't that same. This is not that workforce. This workforce is tribally led, tribally run. It does have a certification board, and Julie had mentioned in a meeting last week, Friday, she mentioned, well, how we get the state one? It's like, the state is not the issue. It's the tribe, it's the area office, it's a federal agency that's doing the certification of it. So it doesn't need to go through the state structure at all. There doesn't need to be a certification under that. So getting out of that mindset, like Dr. Diomera, yes, that stated, it's like getting, I want to make sure I said that right. that we're not following the state structure. We're actually paving a way, a pathway forward that's not typical. So that's my spiel on the Arizona portion of it. But if you have any questions, there is a workforce assessment that we did do. It's going to be published in December. We have a assessment, and I want to note that my goal for Arizona is that I want to develop a toolkit, because it's not just the tribe. Each community has to do an assessment to figure out what workforce they need. We can't go into a community and say that this is what we think that you need. These are the workforces that you need. Maybe they don't need behavioral health aides. Maybe they just need dental health aid, oral health staff, or maybe they just need behavioral health aides. Like, we can't come in and dictate, but I want to be able to create a toolkit for tribes to have a starting map to doing it, because there's not one that exists here in Arizona. And we did try to work with Portland area, but Portland area and theirs was not reflective of Arizona. So creating a toolkit and a sample is actually very important to make sure that tribes can do the work, because we're a small tribe. We are not a big tribe. We don't have a lot of money, but we do know, and we're very aware that we have to establish partnerships with other tribes in order to move forward. It can't be done by just one tribe, and an institution is not going to want to bet $100 million on a workforce based on one tribe. They want to know that there is going to be an impact statewide. There's going to be impact on the workforce. So if you're going to ask for money, you have to be able to have a big idea with big partners that are willing to actually get on board. So that's it. Thank you.
Okay, that's so wonderful. I have so many questions for all three of our speakers. And if we could just give one final giant round of applause for our three speakers. They were all so amazing and provided such unique perspectives on each of their respective programs and where they are in terms of growth. So this is the portion where we wanted to take a few minutes to just open it up for question and answer. If you all have questions for our panelists.
Well, good morning. Thank you very much for all that you have been sharing today. My name is Jeff Hernandez, and I am the Assistant Vice Provost for Career Readiness Strategy here at Northern Arizona University. I'm very proud to be here learning from you all the experience that all of you bring today. It's such a privilege. I'm very grateful that as a university, NAU has partnered to bring you all here so that we learn from you. But I would quickly like to ask any of you, whomever wants to share some information. What have been the most valuable contributions that you have successfully received, managed to materialize when working with universities when it comes to preparing professionals to meet the needs that you have identified? And what have been actually also the challenges that you also have encountered in partnering with higher education institutions to receive support? It is important to understand that career readiness for anyone in the workforce involve academic understanding and insights that equip our future generation of professionals, but also all the career preparedness on the fields that can help them have perspective, sensitivity, and overall, as our first speaker today mentioned, fulfillment in practicing what they will be practicing in the future. So these would be the two things that I would be interested to hear. Thank you.
Both, okay.
So I will say, the successes, so we've had challenges and successes, in working with academic institutes. I would say for us in Alaska, the successes have been working with partners who are willing to, embrace our required curriculum. So when I say that, when we talk about the standards and procedures, there are specific courses and curriculum that are attached to those. And those have been designed to really define, like, if you want to develop a quality behavioral health aide who can provide this range of services in a quality way, in a culturally informed way, in a way that is applicable to their communities, here are the different things you need to know how to do, and you need to know how to practice, right? It is very specific to BHAs. So the success comes when you have a partner who is willing to embrace those things and then say, okay, we can embrace that and fold it into our model. The challenge comes when you have organs or academic institutes who say, well, this is our established curriculum, you have to map it on to this one, but there are things that are missing from that, or things that might be in conflict with how we're actually trying to grow the BHA program. So the success comes in embracing what is already established and required for BHA. The challenge comes in trying to stick with kind of a cookie cutter model, if that makes sense. And the other challenge I would say is that when you map it onto an academic program, sometimes the challenge comes in the GERs. You've got someone who they've identified themselves as wanting to be, or the community has identified them as being a quality candidate for this position. But now you're putting them into a system where they have to take English, they have to take science, they have to take math, and oftentimes those become barriers to them being successful. And it kind of deters them away from the path of what could have been a good thing for them.
I don't know if you can hear us, Dolores, but wondering if you might have anything to add to that question.
I think this is a good example too, when you're working with rural and remote communities and learning just how we're navigating this. Oftentimes we're spending a lot of time with our students doing this kind of stuff up front, so we make sure everybody's ready for when it is course time. But I would echo what Dr. Owens said. And I shared that in my lessons learned with our two different training institutions. But in addition, one of the gifts that have come out of that is when we have our graduates and our providers involved with the QI process. And when you have true partners, we know that working in Indian country, when you have so many tribes who are involved, you have to go slow to go far. And I guess it's basically practicing in a culturally safe way, and you're doing trauma-informed care, but you're doing it in your partnerships when you're collaborating with the schools, the tribes, with the Portland Area CHAP Certification Board, as well as the Northwest Portland Area Indian Health Board. This all gets very confusing if you don't work in that IHS arena. But we all have different priorities. So that's the greatest gift when you can come together. In Arizona, if you're looking to develop your program, we had the best TA conversation with Oklahoma last week, Southern Plains Tribal Health Board. Doug, who is designing their curricula there, I'm just like, I am so glad that he is learning from all of the rest of us, from our lessons learned. They're going slow to go far, and they're designing a great program there. So I think that's the biggest thing. And to be prepared for changed, that succession planning. You know, when we lost that one person who knew everything what behavioral health aides were, and she suddenly wasn't at the school anymore. And then when we lost some of our instructors, you know, the students were not getting the same experience, but that is where Alaska was there ready to help support us, because we were asking, you know, how do you assess the schools? They actually had a crosswalk already in place. Then we were calling back, what do you do when you might have to fire the school? Which we didn't have to do, but you know, what do you do so you can remedy things? So the training program is meeting standards and procedures. But what's more important for all of us, we want to make sure that those behavioral health aides, they are ready to practice. They know everything necessary to start, and they know how to access support for when they are out there.
Okay, I'm talking into two mics. Are they both the right ones? So thanks so much for the question, and thanks so much for the answers, you all. I feel kind of compelled for us to go ahead and break because I don't want to stand between you all and food because we're already 10 minutes behind. But if we could just take one more second to give our gratitude to these speakers. And I know Julie has a gift to present them with. Thank you all so, so much for sharing your expertise. And then I just want to remind folks that the Slido QR code can be used to submit questions throughout the day. And it's looking like we're probably not going to have as much time for those live Q&A sessions as we had hoped. So we would welcome you to submit those questions via the Slido, and we'll work on the back end to see how we can get everyone answers to those, even if it's after the conference is over today, we could send them out after the fact. And now I think Nick maybe has a couple of notes about lunch. Is there anything? Poor Nick. Thank you, Nick. He does the mics. I know he's getting all his steps in. We're supporting his well-being today.
Lunch is ready. I know we had some gluten-free requests. If you're unsure about something, just track down one of the NAU employees and they'll let you know. But it should be pretty straightforward if it's gluten-free. I know there's one other person with like a food allergy or they're doing some sort of diet. I'm so sorry. We tried our best to accommodate. I'm hoping there's something out there that you can eat, but if not, let me know and we can figure something out. Enjoy lunch. Yes, we'll be back at 12:30 and we will be starting promptly at 12:30. Just we have a lot to get in this afternoon and we want to make sure all of our speakers have enough time. Thank you.
As well as desserts. So we would just encourage you to help yourself. Feel free to have as many desserts as you like. No one's judging you. So we're going to go ahead and move into our afternoon session here. And as Julie queued up for us this morning, this whole day is really the result of many conversations and lots of input gathered through the Behavioral Health Advisory Committee. And at the end of that, there were some key topics that came up in terms of need within our behavioral health workforce and opportunities for growing these particular skill sets. And so these next three innovation sessions are going to focus on some of those key themes that came out of those conversations. So we're going to be first highlighting technology use in behavioral health. We're going to then move into pathway programs and creative educational pipeline solutions. And then we're going to end the day with a discussion about integrated behavioral health. And so much like this morning, we're going to introduce both of our speakers for each of those sessions. And then if we have time, we'd like to also open it up for questions from you all. So to kick us off and talking about the use of technology and behavioral health, we have Kate Taylor and Adrienne Matapetti. Did I say it right? I don't know. Okay, I hope I did. She's not here, so if I didn't, then I don't feel so bad. So first up is Kate Taylor. She's the Regional Director of Clinical Outreach for Charlie Health. She is a dynamic social worker and Regional Director of Clinical Outreach at Charlie Health. She's drawing on a background in research, philanthropy, and community advocacy.
Kate brings an innovative approach to addressing the mental health needs of Northern Arizona. Her work is deeply rooted in a commitment to improving access to care and reducing suicide across underserved communities. Originally from Houston, Kate's career reflects a dedication to bridging systems and sparking collaboration across disciplines to create meaningful, lasting change in behavioral health. Our second speaker on technology will be Adrian. Adrian is an MS, DMSC, and a lecturer in NAU's Department of Physician Assistant Studies. She is in the Department of Physician Assistant Studies. Her research focuses on the intersection of healthcare delivery, population health, workforce development, and program evaluation. Adrian also leads the development of NAU's Substance Use Disorder Training ECHO program, a CME initiative aimed at expanding workforce capacity to manage patients with substance use disorders. Previously, Adrian spent 10 years at ASU serving as Director of Project ECHO, Program Director for multiple graduate programs, and Senior Lecturer in the College of Health Solutions. She's currently pursuing a PhD in global health, focusing on healthcare workforce development and program evaluation. Adrian earned her MS in healthcare delivery from ASU and a BS in human and health performance from the University of Louisville. Please welcome Kate and Adrian.
Both nice. Cool. Hey, y'all. I'm Kate. Listening to that being read out reminded me I probably need to shorten the bio and choose some more creative words. I'm going to start a timer for myself too, in case I drone on, but it's great to be here with you. Charlie Health is who I work for. I will not do death by PowerPoint. I just figured it'd be nice not to have my face behind me while I speak, kind of like Brooke. I appreciate that. So, really excited to talk to you specifically because what we do at Charlie Health is super special, really important to me. I have my own lived experience. I didn't come to the mental health field by coincidence. Actually said I would never do it. My dad's in recovery and was the CEO of the Council on Recovery in Houston, Texas my whole life. So I was like, oh gosh, I don't want to do that work, right? Grew up in it. Alas, here I am working in substance use and mental health, but really found my journey here because I went through it. That's the short answer. Flagstaff is the one place that's always made me happiest. It is my home. It is the place that I feel whole. I love this community. And when I finally was able to move here, after thinking about it for 16 years, I worked at the hospital where I was fundraising for the behavioral health unit. And coincidentally, also some of our providers who died by suicide, and was like, wow, there's a big gap here. Having grown up in a city with all kinds of resources, that wasn't something that was as prevalent, but knowing how unique rural and especially rural communities with so much tribal presence, which is less of a thing, unfortunately, in Texas, just realized there was something missing. So when Charlie Health reached out, I say it was kismet. I was called to do this work and feel really grateful to do it now across the state, but predominantly for the last 2.5 years across Northern Arizona. And really 2/3 of the state. So there you go. I covered like Wickenburg, Pace, and La Paz County too. So I think they tricked me by saying Northern. Nick, or whoever's controlling slides would love to go to the next one. So just to frame up kind of what we do, but also why I'm here, Charlie Health exists for a really important reasons. So our name Charlie is not by coincidence. We have 3 founders at Charlie Health. Our CEO is Carter Barnhart. Justin Wise is our CFO, and our CCO, who is a social worker. Woo, love social workers. I am one. Mighty little BSW. One day I'll go to grad school when someone else will pay for it. But still working on that. Thank you. Charlie was best friends with Justin in particular. Our CCO, by the way, is Dr. Caroline Finkel. He died of an accidental overdose. He was struggling with co-occurring mental health and substance use, was sitting on wait lists to get treatment, and unfortunately wasn't connected in time. So what we did as an organization, and I wasn't here from the very beginning, but we're a startup that's been around since 2019, and feel like I'm honorary veteran at this point because it's a young organization. Is we worked to democratize a level of care that is historically really inaccessible, especially in rural communities. So Charlie Health is what's called a virtual intensive outpatient program, or IOP. Oh, thanks for this clicker. I feel empowered. If you're not familiar with the behavioral health landscape in a really intimate way, this visual is helpful. So, most people know of traditional inpatient care, right? Your psych ward, where you go when there's an emergency or feeling like you're actively going to harm yourself or someone else. There's also therapy once a week, or maybe a little bit more frequently, often not, usually a little less frequently. We fit in the middle of that continuum. We're working upstream, which is my favorite place to work, to prevent hospitalization, because especially for folks coming from rural communities, we realize it comes with a whole host of trauma and also disconnection from your loved ones, because you usually have to go pretty far away. So as you work on your recovery journey, it's hard to involve folks that love you. On the other side, we're the downstream approach, right? You've already been there. You're probably needing a little bit more. So this just gives you a little bit of an idea. The reason we chose to be virtual as an organization was to eliminate the wait time, most importantly, but also because what we know we're limited by in smaller communities is the fact that you may not always have the right clinical expertise. Unfortunately, the reality is oftentimes that people aren't paid enough to live where they want to live, especially in smaller communities. And also you have people who are incredibly ambitious. They may be from a tiny community, but they're like, you know what? I want to be an expert in this one topic. And local communities can't always foster that level of expertise or grant someone the experience they need to cultivate an experience that meets their goal. So with Charlie Health, we said, you know what, like, we don't want folks out to ever wait. When you're ready, and that moment is really important. And when we wait or we forsake that moment, the outcomes are often dire. The second thing we said is, you deserve the best level of treatment possible, regardless of where you live. And so by pivoting to a virtual model, what we did is we created an experience that allows people to get care that is really specific to their condition, to their lived experience, which is so important to us. And also to making sure you're connected with other people who get you. If you're that Black trans Jewish kid in Flagstaff, Arizona, I'm going to tell you, you're the only one, because we don't have a lot of diversity here the way that you might in Houston, Texas. And so being able to help you sit in a room with other individuals, because a level of care like ours is heavily group focused, who really get you and help you feel connected and not isolated, is so important to your healing process. From the standpoint, I love to storytell. By the way, I am, this is a humble brag, but Brene Brown and I went to the same university. I know, hook 'em. She's also from Houston, and my dad actually taught at the Graduate College of Social Work with her at U of H. But all that being said, I think that stories are how we learn best. Stories, especially living in a place like this with so much Indigenous presence, right? Where storytelling is how we learn to be in the world, is really helpful. So let me do a little time check. Almost halfway through. So I think what I really want to get at here for y'all is, by being innovative in how you approach care, you can allow people to heal at home. So I'm going to tell a story just because I really like doing this, actually. We have Naya and we have Sammy, right? So Naya's 20. She's got kind of a unique experience. She's in college. This might look like an NAU student, and I work with NAU. So I know that the need is here. She unfortunately was sexually assaulted in her freshman year. Her school counselor that she goes to can't see her very frequently. And she's worried that if she doesn't get the help she needs, she's probably not going to make her graduation, because she's having experiences that really limit her from being able to focus in class. Sammy's got a different reality. He's 27, which is really different from being 20. He discharged from the military and he's struggling with suicidal ideation. He's learned that smoking cannabis helps him feel a little bit more chill. It numbs kind of that experience of, existential crisis, which I think most people are feeling on a big level these days. But he decided to check himself into the emergency room a few days ago because he really was having some active thoughts and was concerned about what he might do. And she's just feeling hopeless. In a traditional setting with a care like ours, you'd see these two individuals in the same group. What we might also see is that they've been sitting on a wait list to get into this group, and the people alongside them are struggling with things that are really, really different from them. Their identities are different, their lived experience. And so they sit there and they go, man, why am I here? And gosh, seems like it sucks all around for everybody. Oof, I don't feel very connected. But more importantly, they're usually seeing generalized therapists. What I can say too for local communities is, it's difficult to have the right people at the right time in the right moment to be able to facilitate that experience that's truly life-changing. We don't always have capacity because we don't have enough staff to make it possible for folks. So we basically just came up with a model that eliminates that barrier. Because we're virtual, we're not limited by who's ready at what time. We have a bigger base of clients that really need care at different times. And for the purposes of this conversation and just encouraging folks who are in their education, what I think is important to take away from this is it doesn't matter whether or not, actually, let me back up. Sorry, I'm an extemporaneous thinker and presenter. I go off script often. Nobody should be limited because they want to serve their home community or they want to live in a certain community. I love Flagstaff, Arizona. I am also a very, very ambitious human being that believes deeply in making huge impact. And there's a lot of opportunity here, don't get me wrong. But I think that same opportunity and someone in Snowflake, Arizona, who maybe wants to go back and make an impact in Snowflake shouldn't be limited by only being able to work at ChangePoint. They should also have alternative options, even if it's they work at ChangePoint and somewhere else where they can really deepen their clinical understanding and specialize, and then just be better for that local community. I think it's super special. I know that we live in a traumatized era of we all had to go through COVID, Zoom trauma, and gosh, we want to be back in connection with people in real life. I would never argue against that. I mean, I get to be in real life all the time. But what I will say is that being able to operate in a virtual capacity is going to give you so much exposure and experience to being able to both increase your educational opportunity and also learn to work with folks from all over. So that's just a really important thing and something I would encourage folks, especially with models where what's come from COVID is a lot of people now are virtual first rather than a virtual afterthought or a virtual hybrid. So you don't have to just choose it because it's the only option or, oh gosh, this is just today. It's like, oh no, we cultivated everything this way. And we did it so intentionally that you're going to have an amazing experience. The other side of the innovation for this is at Charlie Health, and I don't have a visual for you here, so just roll with it. I'm going to hope that I explain this well. We have integrated AI on a totally different level, and that scares people, especially in behavioral health, and I get it. It scared me when I first thought about it and everything else. But for our groups, we have Party Charlie, that's his name, official language, and then Charles for our individual therapy sessions. What's really cool is as a practitioner, one of the biggest pieces of feedback we had, because we're research-based, so Yale and UPenn and Florida State University are all our peer-reviewed research organizations are studying outcomes at Charlie Health constantly. And we've got a whole lot of boring slides for you here, although for this audience, probably not boring, which is fun because I'm a nerd. And our clinicians kept saying, gosh, we are having such a hard time keeping up with notes. Any clinicians in the room? Anyone feel that? Yes, right? You're like, or you're sitting there and your client's looking at you and they're like, what are you writing down? I know I've done that with therapists. I'm like, I just told you my whole life story. Oh, I'm nervous. And so it makes you uncomfortable because you're and then that clinician's trying to write this down so they remember it and they know what to respond. But then they're also trying to be present with that client and have the body language that reflects their understanding, that empathy and everything else. And so as a company, we said, why don't we alleviate that pressure on our staff? And we made Party Charlie and we made Charles. And now what's super cool is all of these notes are being taken live. I mean, clients sign off on this and their consents and all that. I know from my regulator in the back, we were getting into it. So don't worry, we're not doing anything shady. But what's even cooler is in a caseload where the reality, especially in community mental health, so anyone from the Guidance Center of Southwest Behavioral, y'all know this, right? Your caseloads are insane. Is now suddenly you don't have to keep track of everything just in your brain or just on your written notes, but our algorithm can tell you and put into a sheet the risk levels of each of your clients. And during session, they can tell you, by the way, your client mentioned they love horses and that recently they went out to visit their horse, and you should probably use this DBT skill in this way and relate it and ask about their horse. And it's just super neat because they feel less pressure. They're like, wow, I'm keeping up. And they can see their caseload coded by risk. So red, right? Like you need to more frequently reach out to these clients. Orange, these clients, we're doing pretty good, but you should probably consider making sure that you're regularly checking in with them. And then green, these are your clients that are doing great. So just all to say, like, I think that part of being open to being a virtual provider, in your career, exploring these, not writing them off, will allow you to actually participate in an experience that's going to make you better and more dynamic. The reality too, I hear this all the time from clinicians as I connect with them, is they're like, well, my clients just want to be in person. And then suddenly we go in person for 2 sessions and now they only want to be in virtual. And I get it, right? We want to build trust and rapport in person. But the reality of our clients that we're working with, especially in rural and tribal communities, is that it can be a long commute for them. Gas, not super cheap these days. Kids get sick all the time. You're struggling with a chronic illness, you've got to go to the doctor, or your body doesn't feel great today. And so that option's going to come up for folks. They're going to want to do it. And the more empowered you are as a provider and comfortable in this setting, the better you're going to be able to serve the people you want to serve. And also the more expert you can become in all of these areas that you may not have even known existed, because you don't have to specialize in just generalist practice, but you can become that expert in one area. So that's the whole of what I've got for you. I'm going to stop talking. Just say, like, the other thing is you can also provide a really comprehensive level of care still virtually. We don't take things lightly. Our clients, more than half of them have attempted suicide at some point in their life, and that's not a casual level of care. Most people go, well, how do you monitor clients there? So anyway, there's a way to do it in a cool way. And wow, 15 minutes. Okay, perfect. That's what I got.
So that was amazing. I have so many questions. I don't know about you all. Kate does have to leave a little early today, so we thought we'd provide a little bit of space right now if anyone has questions for her before she has to take off. Does anyone have any questions for Kate right now? And folks online can certainly put them in using the QR code. Folks in the room can do that as well. And if you don't have questions, I have questions. So how about, if it's okay with you, I'll ask a question. So how can learners, I know you shared a little bit about how Charlie Health is currently using AI and analyzing patient data, assessing risk level, et cetera, which I personally find so cool. How can learners prepare to work in this new and dynamic environment? Because I know, we're interested in figuring out how do we create this well-prepared workforce. So what would you have to say on that topic?
Sure. I think what I would say is never underestimate the opportunity to learn in a non-traditional environment. What I mean by that is, like, role play with your friends. It doesn't have to be a professional that's doing this, but get comfortable in Zoom just on your own, right? Do you host, can you do an ad hoc, I guess this is outside of your education ambition. It's just like, if you dream something, you want to make it happen, make it happen. We do a lot of role play in our roles. I know our clinicians have too, but just getting technologically proficient and comfortable in the setting in a low pressure environment will help you be prepared to do it in a high pressure environment. Well, I don't know if that's a good answer, but that was what came to my head.
Look at you too. Do you ever run into any situations with network connectivity issues in rural areas that you've stumbled upon, or ways to navigate that?
Yes, we do. Not as frequently as you might think, though, right? I work deep on Hopi tribe, deep with Navajo Nation, White Mountain Apache, you name it. Connectivity's gotten so much better over time, which I'm really grateful for. That's huge. Actually, my job in Houston was Center for Survivors of Torture. I worked in a free mental health counseling clinic with refugees, asylum seekers, and immigrants. And happened during COVID. And so we had to pivot and be virtual, and we actually saw an increase in access. At that point, I really had to leverage like my own brain to get a Verizon business plan and hand deliver some tablets through a grant that I got and stuff like that. But a lot of local libraries provide hotspots you can check out. We personally, as an organization, have worked to eliminate barriers. So we provide free tablets for our clients that we don't ever ask for back. What I've done in my experience with Charlie Health in the last almost 3 years has been leveraging partnerships with local community, that's a chapter house that can create a room where someone can use their tablet and hook into the Wi-Fi. If that's a school, and I have a partnership with that school counselor that can set aside a room for that kid to go in and participate. So, it doesn't have to all be independent. We live in America, the United States, where a lot of times we're told we have to be, but community is a powerful thing. Working together with other people can eliminate some of those barriers. And connectivity, yeah, you can get creative. I lived in a van for 1.5 years, and I worked remote and connected to Zoom in rural Wyoming. So on a hotspot.
Yes, it sounds like maybe one more question in the back. You want to just yell it and I'll repeat it? The question is about patient perception of utilizing technology such as AI and telehealth.
I love that question. If I had my slides, I would show you our patient satisfaction scores. Patient perception is pretty incredible. So when Charlie Health was born in 2019, we started with the age range 12 to 25 because the adolescent mental health crisis, right? That was how we began. And we were meeting youth where they were, right? So social work operates from that framework. You got to meet the client where they're at. So naturally already folks were online, and then the whole world was online, and we're like, gosh, people need this beyond that age range. Our patient satisfaction rates with clinicians are 96% for their primary therapist assigned, 91% for the entire, like the group curriculum, their whole overall experience, which is incredibly high. And the reason, truly, because it's kind of mind-boggling to think about a 16-year-old recommending to their friends and family 12 hours of therapy a week, and they do, is because our clinicians are so damn good online. They love being virtual. They are so engaged, and we have recruited. It is very, very difficult. We hire 1% of anyone that applies to our organization. 1% of people that apply to Charlie Health get a job at Charlie Health. It is very elite. And I'm not saying elite in a bad way. It's because we get experts. We get people who care, and they are creative. We have clients log on. My favorite story, we'll tell a story. Dr. Eli is our chief medical officer. So he runs psychiatry. He had this adolescent log on for a session one day, and our psych team is really small and they don't have a lot of time. And this kid was camera off, which is not how they're oriented to our program. You got to be camera on. And they're just engaged. And Dr. Eli's like, hey, how are you? And like asking a bunch of questions. They're like, fine, one word, blah, blah, blah. So finally, Dr. Eli goes, is there anything, literally anything at all today that I can do for you to help you? And they're like, well, there is this one thing. And they turn their camera on and they go, can you get me a cat? Dr. Eli is like, well, actually, technically, I can prescribe a cat. So yeah, I mean, emotional support animals and blah, 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 goes into this whole spiel and goes, where's your dad? So dad walks in the room, right? And all of a sudden, like now the next session, same thing, logs on with this kid logs on, and kid's like all disengaged. And it's like, oh gosh, like, oh, here we go again, right? So Dr. Eli is like, doing his warm thing. And all of a sudden the person turns on the camera and they have a kitten on their head. And so this is what happens all the time, but really the biggest satisfaction or the engagement piece comes from the connection they have, both with their clinicians, but also with each other. When you log on to a session and you're a 15-year-old who's neuroqueer, you're autism spectrum disorder, and you're also a member of the LGBTQIA community, and you've struggled for 2 years to communicate with folks because nobody understands you, and it's so exhausting to explain yourself. And now suddenly you sit in a group and you're like, I didn't talk for 2 years because what the heck was the point? It wasn't worth it. And someone else goes, what? You did that? I've done that. I had no idea anyone else did that. So that's really where the engagement and the satisfaction comes from is each other too. And that's the experience we've worked to create. So hopefully that's a good answer. I don't know, but I like to storytell.
Can I ask one more? I'm going off script here a little bit because when we met with Kate to prep for today and she was talking about using AI to stratify risk level and then AI recommending evidence-based approaches, like all of those things make all of my everything light up like, yay, evidence-based, yes, risk stratification. So I was very excited about it. And I have the privilege of working with college students. So I walked out of my office and I said to some in training counseling students, hey, what do you think about this idea of using AI to stratify risk and recommend effective evidence-based clinical interventions? Those students were like, no, I'm in this for the connection. I have the expertise. I don't want AI telling me what I should be doing with my client. So that was a small N of like 2, but it was my experience. And so I just wanted to ask, like, because if we're the training university, right, we're graduating these folks, what sort of things might we want to encourage our current students to consider that to make them a little bit more amenable to using technology in their future careers?
Yeah, I respect their answer. We had clinicians that also were like, not so sure. The biggest thing I would say is like part of, so I'm a social worker, right? I grew up in a place where people were from all over and really, really different. And my mom was an inner city high school teacher. My family took being a part of a community in a different kind of way really seriously. So equity is a huge part. I know it's a scary word these days, but it's a huge part of who I am. So if you really want to serve others, right? Like for one, as a learner, growth mindset's essential. I read that book before I went to school and changed my life. Had a lot of fixed mindset. So for one is like being open is important because at a certain point, you're probably going to be forced into it. So you might as well take control of the experience early on and just lean into it. But the second piece of it too is being able to make a larger impact, and also especially for communities where there are more barriers, being willing to lean into that is going to help you just make a bigger difference overall, especially in this field. So yeah, growth mindset / equity and impact would be my answer there.
Thanks so much, Kate. Next, we have Adrian here to talk to us about Project Echo.
Hello, everyone. I'm glad that Kate and I coordinated outfits today. So I'm here to talk to you about Project Echo, which I've been really excited has been mentioned a few times already, has been utilized out in the community and the work that you're doing, which is very exciting for me. I'm very passionate about this model. So some of this might not be new to you if you're already using the model, but I wanted to make sure everybody knew that this model is out there. It's available. It's very adaptable. We're a replicating partner here at NAU. So if you're internal with NAU, we can start programs here. And it's easy, relatively easy if you're outside of NAU and not a replicating partner to become one. As I go through this, I would just encourage you to think about how you could apply this model into the work you do and how you could leverage it to enhance the work you do. So Project Echo. Echo is an acronym. It stands for Extension of Community Healthcare Outcomes. A little bit of the history on how Project Echo was developed. It started at the University of New Mexico by Dr. Sanjeev Arora, this gentleman here. Dr. Arora is a hepatologist. Back in 2003, Dr. Arora was one of 2 hepatologists in the entire state of New Mexico that was treating hepatitis C. At the time, they had about an 8-month wait to get into their clinic. The gold standard treatment then was a chemotherapy-like drug called interferon. Because of the toxicity of the drug, primary care providers wouldn't touch it. So they had 2 providers in the entire state treating patients with hepatitis C. The real kicker is that interferon had a 70% cure rate. And Dr. Arora got really, really tired of having the conversation of, if only I saw you sooner. And he thought, we have to look at our system and think, how can we do this differently? We have a life-saving medication and we can't get it to the patients who need it. So he started to think through, okay, how do we get this treatment out into the communities where patients live. And so you kind of thought through, okay, well, there's the recruit future medical providers from rural areas and hope they go back. There's encouraging them through loan forgiveness programs to go and work in rural areas or underserved areas. Specialists could go set up shop in a rural area one day, every few weeks, a month, and try and see as many patients as they can on that day. None of these were really moving the needle. And so we thought, okay, how did I become a specialist? We thought, well, I saw patients. And then I had an expert and a mentor to review that patient with, got consultation on that, and then went and saw another patient. And in his words, I did that for 2 years and they started calling me an expert. And so he thought, well, we already have, when we look at the disparity of healthcare providers in terms of provider to patient ratios, it's massively large when you look at specialty care. It's much more equitable when you look at primary level care, family practice. And so we thought, okay, if we have providers already living and working in rural areas, they're not limited by their license, they're limited by the knowledge and the confidence and the mentorship to treat higher acuity patients. So we thought, why don't we leverage this? And so he created the first ECHO program, and he virtually trained, I think in the first program, they had about 35 or so providers in that first program, and he trained them to treat patients with hepatitis C. A year later, they did a study. By 6 months, all of those providers were treating patients in their local clinics. After a year, they did a study and found that those patients being treated by their local provider were actually having better outcomes and less adverse events than his own patients, Dr. Earl's own patients in his specialty clinic. So it's expandable, it works, and since then has scaled massively. So that one program started back in 2003 is still running today. Actually, best practice care for hepatitis C treatment has changed 5 times in that time period. And now there's thousands of programs around the world. I think in total, over 7,000 ECHO programs have been built. I think this one is a snapshot of active programs, so 2,500 active programs going on around the world. There's learners from every single country. I kind of find it ironic that I'm here talking in the technology piece because I'm not technologically literate. I'm not, nobody comes to me for tech advice. But the beautiful thing about Project ECHO is that it uses really simple technology in a really powerful way. All you need is cell phone service and you can participate. So it's really expandable in really resource-strained areas. So what is it? The mission? The mission of Project ECHO is to democratize medical knowledge and amplify capacity to get best practice care to underserved people all over the world. Move knowledge, not people. It's so much easier to move knowledge into the communities that are needed than to move the people into those communities to treat, or to move patients from those communities into more urban areas where specialty care exists. We call it an all teach, all learn model. We view everybody on the call. We have a team of experts on every call. We call them the hub team. They're a interdisciplinary team. We kind of, when we think about ECHO programs, we think, okay, who's the dream team that you'd want to have in a room to provide comprehensive care for a patient in whatever topic area. We create that hub team. They're on every call. But all of our participants are experts as well, and they're developing experts in a particular topic area. There's many examples where providers have started as participants and ended up as the expert on a hub team. So it's an all teach, all learn model. Again, moving knowledge, not people, much easier to do. And the results that patients get healthcare needs met in their local communities by providers they already know and trust, who understand their social circumstances, who speak their native language, so that you can see the connection and the barriers that it can knock down by implementing this simple model. The other thing, there's been quite a bit of study on the model itself. It's part of the work I'm doing in my own PhD program. But a couple things regarding the model. It's highly adaptable. It's very easy to replicate. Couple stories, one story regarding its adaptability. So prior to my role here at NAU, I was at ASU, and got to be involved in implementing Project Echo at ASU. As part of that work, we spent about 6 months. The very first program that we stood up was a medication for opioid use disorder program. We spent about 6 months planning that, got a team of experts lined up, and launched the program in February of 2020. So you can imagine the timing of that program. So about a month in, obviously we hit COVID. We essentially just threw that curriculum that we spent 6 months planning in the garbage because everybody's needs had changed. And we had policymakers come in, and we would do at the beginning of each session, we would say, here's this program ran every other week. We would have an expert come in and say, here's the policy changes that happen, and here what it's gonna mean for your practice. So what we did is we took a very fast moving, changing environment. We had a team of experts whose job was to keep track of what those changes are and then disseminate that every other week to the providers in the community, which saves 75 other providers, which is about what we had on the call, each call, doing that individually on their own. So all they had to do was show up and get that information. And there were fairly significant changes, such as prior to COVID, all treatment for buprenorphine was done in clinic. And all of a sudden they're able to do 30-day take homes, which is a massive shift for providers and patients. The other thing that happened in that time is I had a colleague call me up. She was in the Doctor of Behavioral Health program. And she called me up at the very end of March and she says, we have to launch an ECHO program in behavioral health. And I said, okay. She's like, there's just the need is increasing and massive. And when she phoned me with that, I said, okay. I said, when do you want to launch? And she goes, next week. I was like, what? I was like, no, okay, let's do it. Let's launch a program next week. We basically created a flyer and recruited 3 experts in that time. We had our first session the following week, 120 people showed up. And we said, what do you need? The session was just information gathering. What do you need and what resources can we help bring to you? From that, we got telehealth. How do we do it? Because behavioral health is not was not utilizing telehealth at that time. How do we be HIPAA compliant? What platforms can we use? How do we have a safe environment when we have youth coming in, zooming in from their homes, and things like that? Answering those questions. And the second was workforce wellness. Our own workforce was being extremely impacted by COVID. How can behavioral health providers protect themselves? And how can they show up for their own coworkers in a way to keep them healthy? And that's where that program began. Both of those programs are also still running today. All right, the model, telemedicine. I like to compare it. The easiest way for me to describe this model is to compare it to telemedicine. So telemedicine, you have one remote provider treating one remote patient, where that provider assumes care of the patient. They can bill for that patient, they prescribe, they follow up, and are responsible for the care and treatment of that patient. What we do is called telementoring. So instead of having one expert, we create a team of experts. We try to make that team as interdisciplinary as possible. We have providers, medical providers, but we'll also have social workers and pharmacists and psychologists, community health workers. Sometimes we have patient advocates and patient representatives on that program. They meet with those local primary care teams, train them in whatever the topic is, and there's hundreds of topics. It's also expanded out of healthcare into education and other fields. And then those local providers retain care of their own patients. So there's no referral happening. They get the consultation they need, and then they come in and treat those patients. Each session is about an hour long. Some are 2, some are 90 minutes. Most of the ones that we've run are 60 minutes. About half of that session is didactic, and the other half is case-based learning, where the cases come from the local providers. So they're real patients that they're seeing in their local communities, where they bring everything scrubbed. We don't talk about any PHI in our sessions. All of these programs are free. It's mandated by the Echo Institute, which is based at the University of New Mexico, that all programs are offered at free, and whenever possible, the CME that you provide or the CEUs should also be offered at no cost. Our programs offer 6 types of CME and CEUs free in the programs that we run. So our program here at NAU. So we have the first program here is the Substance Use Disorder Training ECHO. It's launched out of the Department of Physician Assistant Studies. There's kind of 2 main arms to this program. One is the ECHO program itself, which we are training providers who are already living and working in rural communities to treat patients with substance use. The other arm of this program, which is a little bit unique, is that we are also training the future healthcare workforce, our PAs. So our PAs get their curriculum through the ECHO, so they're in training with current providers while they're still in their training program. And in their second year, when they're out on rotations, they do a substance use disorder and a behavioral health specific rotation. So that's now baked into the curriculum and their training. This program is sponsored by SAMHSA. We just entered into year 2 of a 3-year grant for this. Some of the outcomes. So to date, we've offered 21 sessions. We've trained 277 unique providers since January. We've provided 757 hours of free CME or CEUs, and our overall satisfaction rate is 4.8, so 96%. The outcomes that have been really important for us is increasing knowledge. The greatest one that we've seen is treatment of polysubstance use, which we've seen the greatest growth in learning. We've also seen increase, we also look at confidence. So great, you have the knowledge, do you have the confidence to go forward and integrate that into your practice? And the greatest confidence we've seen is providers or future providers have the confidence to work with patients with a substance use disorder. And this is really important to us because when we've talked to programs that run addiction medicine programs, one of the things that they've said to us is that the biggest barrier is getting providers to feel comfortable enough to treat patients with substance use disorder. And that can, a big piece of that is just getting new providers in front of patients, seeing patients as people and not worrying and starting to break down that stigma right away in their training programs. The other piece I want to mention that we also evaluate as part of this program is clinician wellness. There's been a ton of talk today about community. We measure 5 different aspects of clinician wellness. What we see in this program, and this program just started in January, we've seen statistically significant changes among our participants in job satisfaction, in ability to meet patient needs, in value of their own practice. We've seen decrease in burnout. And so, part of that piece of connecting providers who are geographically dispersed, who feel siloed and isolated in the areas in which they work, and connecting them into that community and creating that community of peers that they can rely on every week or every other week to consult with and to increase their own training with. And that's showing in the data that we're seeing. So I think that's my last slide. And open to any questions. I hope I remain relatively on time.
Thank you so much, Adrienne. That was so great. Are there any questions from you all in the audience for Adrienne? Michelle's very curious. You can yell it out and I can just repeat it.
Oh, since Nick wants to run around everywhere. Sorry, maybe it doesn't matter if I have the mic or not. Anyway, the question I know you have a here on campus, and you said there's a health one where it's not through NAU. Where is it at? I guess.
Yeah. So one thing I love about the ECHO community is that there's just no ego in ECHO. We like to share as much as we can and get people connected. So the programs the ones I mentioned, the MOUD program, behavioral health, they also have several programs in speech and hearing science. They have interprofessional training program, all at ASU. And so you can join any program that you see. If we don't offer it, we'll try to connect you with a university or an organization, a health system that does offer it. They're all free. it's mandated by the Echo Institute. So
Are there any other questions for Adrian? If not, I can launch into. So Adrian, what kind of infrastructure and staffing do you see NAU needing to run regular Echo webinars? And how could potentially community partners also be included in instruction?
great question. So actually, I'm going to answer those in reverse. So the unique thing about ASU and NAU in running Echo programs here in Arizona is that neither organization, either institution is an academic medical center. A lot of programs are run out of academic medical centers who have hospitals full of experts that they can pull into these programs to be the SMEs involved in those programs. And then that can go towards their education or whatever that they have. That piece can be carved out of the institutional time. ASU and NAU don't have that. So all of our programs are built in collaboration with community partners. Dr. Aurora is quoted as saying, Project Echo is a project of the willing. So finding the people who believe that knowledge should be shared, that providers in rural areas can and should treat patients at higher acuity with the mentorship and the resources provided to them virtually. In terms of the staff, it's an interesting model. It takes some staff support. It for sure takes a staff person. We found it's about a 1-to-5 ratio. So 1 full-time FTE for every 5 programs that you run is about the equivalent. So we start a lot of our programs with just partial time from somebody. It's relative. It's a very simple model to run. It's a little bit nuanced when you get going because there's lots of little pieces you have to manage. Once you have that, it's a pretty easy, simple program to run. But I would recommend if you're going to have a program to have at least 1 staff person with some actual time carved out for them to run that program.
And I wondered if you could talk a little bit more specifically about how Project Echo is incorporating provider well-being into its programming and how those strategies might also be incorporated into the design of a behavioral health training curriculum that aims to support providers' mental well-being and reduce burnout.
Great question. This isn't something that's widely studied with the model, which is one of the reasons why I've been particularly interested in studying it. We measure those 5 clinician wellness factors every 6 months to see if we're making a change. But one of the things that I have been studying as part of my PhD program is the integration of learning theory in terms of different CME programs. As it turns out, and not related to quality of program, not related to quality of instructor, just literally the models themselves. A lot of adult learning theory is around community, is around interprofessional engagement, is around learners interacting directly with mentors and peers. A lot of that is wrapped up in learning theory, which is underlying everything that we've been talking about today in terms of community. And so that is all supported theoretically of why providers learn well and respond well when they have those environments built around them. So in terms of wellness, or in terms of theory, Project Echo integrates about 96% of different elements of adult learning theory just naturally within its model. It's live, it's direct engagement with experts and peers and mentors. It's direct feedback on patients that they're seeing. So it's not hypothetical situations. It's direct feedback there. There's a sense of humility about it. You're going to be standing up in front of your peers saying, I'm treating this patient and I don't know what to do. So it's grounding in that way. And it's grounding for our experts too, because they have to stand up and say, I'm an expert in this and I don't know where to go. And so in terms of increasing wellness, and I think that's why we naturally see those factors, those wellness factors improve just naturally because Echo integrates with the model itself a lot of factors that touch on clinician wellness.
Really great stuff. Any last questions for Adrian? Thank you so much. Our next innovation session is going to focus on educational pathways for behavioral health workforce. And we have with us today Dr. Pardee, who I believe will be joining us online, and Dr. Sarah Coles, who is here in person. So I will again read their introductions. They'll speak in succession, and then we can have, maybe we can't, nope. Yeah, we can have one person on a panel. Our panels are small today. We're rolling with it. So Dr. Deborah Pardee is a licensed psychologist and has worked in the mental health field for over 40 years. Her experience is diverse, having worked with children, adolescents, and adults with a focus on the treatment of mood disorders, substance abuse disorders, and autism. Her current areas of specialization include forensic psychology and psychological assessment. Her services include assessment of competency for both adult and juvenile populations, mitigation, and psychological assessment. Dr. Sarah Coles is the MD-FAAFP is the program director for the Colorado Plateau Family and Community Medicine Residency at North Country Healthcare and associate professor in the Department of Family, Community, and Preventive Medicine at the U of A College of Medicine, Phoenix. She obtained her medical degree from the University of Arizona College of Medicine, Phoenix, and completed her residency at Banner Good Samaritan Family Medicine Residency. In addition to comprehensive primary care, Dr. Coles has expertise in evidence-based medicine, integrated behavioral health care, and medical education. Please help me welcome our guests.
I'm Dr. Pardee. Thank you for having me. I work with the Guidance Center, as was noted earlier. I'm the psychologist there. Dr. Stephanie Babbitt, our Chief Clinical Officer, is also a psychologist, and she couldn't be here today. So I'm here to talk about our internship program, the Earn and Learn program. And I can't see who's in the audience, so I'm just going to give an overview of the Guidance Center. As many of you are probably aware, the Guidance Center is a regional behavioral health facility in northern Arizona. We serve Coconino County all the way from the border of Mojave and Yavapai and Navajo counties in between, all the cities in between. We provide a comprehensive array of services that include outpatient and management, case management, outpatient counseling from, we have a birth to 5 program. We have counseling for children, adolescents, and adults with both licensed counselors and social workers, as well as me, the psychologist. We have psychiatric services for children and adolescents and adults. And then I'm sure some of you are familiar that we have the Psychiatric Acute Care Unit, the PAC program. We take people who are hospitalized involuntarily under the Title 36 statute, as well as people who come in voluntarily who want inpatient treatment, stabilization of medication, etc. We also have a substance abuse treatment program, which is a approximately 30-day program. And we have a behavioral health residential facility on our campus. So we have a huge array of programs. In addition, and I just came in at the tail end of the last presentation, we are implementing, or in the process of implementing, a residency program for medical students who want to do psychiatric rotation. So that's in the works. It's very exciting. And as mentioned, in my bio, I do a lot of forensic work, which involves assessment of people who are charged with crimes to determine whether or not they're competent to proceed to trial based on any mental health problems that they might have. I also do a lot of mental health evaluations for the court system. So lots of different things that we do over there. And I want to say that I think it was 2 years ago now. I've been with the Guidance Center 3 years, 3.5 years. About 2 years ago, they implemented a program where we pay interns and practicum students. So they get a certain amount of money per hour, and in exchange, they get experience with a wide range of client population. So that typically happens more with master's level students, social work. We have a licensed clinical social worker who supervises our social work interns. We have someone who has a license in clinical mental health counseling who supervises the mental health counseling students, some of which are from NAU. We also get students from other programs, including Grand Canyon University. And we, unfortunately, Grand Canyon University, people can't get paid for some reason. It's got to do with the Grand Canyon, not us. But people, students from NAU are able to get payment as well for their services. So it's a really fabulous opportunity for students to come work someplace and get paid at the same time and get credit for a practicum or internship. Before I came here yesterday, I was talking with Dr. Babbitt because I don't really do a lot of supervision or working in the counseling arena. But we've, asked her how many of the students in those programs stick around. And she thought that it was a pretty good number of students who remain in the Flagstaff area. One of the things that happens with doctoral students from NAU, and those are primarily the programs I supervise people in, is that they have to go elsewhere for internship. So doctoral students going through NAU's counseling and school psychology combined degree program will do a practicum with the Guidance Center. They will do a lot of times field work to get credits for counseling and for assessment, psychological testing and assessment. But to do an internship, they have to go elsewhere, except I think Southwest Behavioral Health in Flagstaff might be accredited by APA programming. We are not. So typically my students leave and they don't come back. I've had students who have gone to Chicago, 2 to Chicago, 1 in DC area, who are remaining to stay where they're placed. Another one's getting ready to go to wherever. She's applied for multiple internship sites. And I think those students, once they get kind of integrated into a community, tend to stay there. And that's what I've noticed with those 2 that I supervised who went to Chicago, that they really like it there. They want to stay there. And they have kind of established roots, even though neither of them are from Chicago. One intends to come back after her internship at the University of Alabama, and she wants to work at Phoenix Children's Hospital for her postdoctoral residency. So those doctoral level students are difficult to hold down or get back. And as such, we right now are looking for a psychologist because I am intending to retire from full-time work. I'll still do criminal work, but I am intending to retire in February of 2026, and we're looking for a psychologist. So that can pose some problems for the community, and that there are probably some psychologists who went to NAU and remained in the community, but after NAU became accredited by the American Psychological Association, which I think was probably about 5 years ago, maybe a little bit more, they have to go elsewhere typically for their for their internship, their doctoral internship. So that's a little bit confusing, but that's what happens. But we try to retain people after they graduate. We've had people who have graduated and stayed to do supervised work for their license. Typically, counselors and social workers, I think on the average, have to have about 2,000 hours of supervised experience before they can sit for licensure for independent practice. So there's a lot of steps for behavioral health people to manage before they get to a point where they can operate independently. That's just kind of an overview. I was told that I had about 10, 15 minutes to introduce this topic, and then if there's any questions, I'm happy to take them.
Them for that future career. We really want our kids in our community to see themselves as health professionals. And for many of us, and I don't know about any of y'all, you might not have had that person in your life who could be that mentor, that role model to show you that this is something that was achievable to you. So we want to reach out to our local high school kids, particularly those that would be first generation college students or underrepresented in medicine, to help them have a career pathway forward into health professions. Obviously, this is geared towards family medicine, but we want to support them in any health profession that they might be interested in pursuing. So we hope that our students by the end of their program will be able to identify career paths forward for them and to develop a post-secondary education plan, to analyze health systems and social drivers of health and how that impacts health of communities and what they can do even now in high school to help support and address those social determinants, and to build skills and interests in health professions. This is a resident-led program. So we want our residents, our doctors in training who are going to be board certified in family medicine, to learn something too from doing this program. So we're teaching them how to facilitate large group teaching sessions, how to prepare and to utilize different teaching strategies for different types of audiences, and then to understand why it is so hard to increase the healthcare professions workforce, particularly in terms of improving diversity. So we've been doing this now for 3 sessions. So we have 2 different models in this program. We have a fall and a spring model. Our first session is a 9-week after-school program led by our family medicine residents that high school kids from our community come and engage in specific training. So an hour and a half on Wednesday evenings, they come and hang out with us. In this training, they learn things like social determinants of health. We talk about advocacy and policy and how this impacts. We talk about career financing and what college looks like and the differences between universities and community colleges, and other skills training courses. We also have them do a research project and a poster presentation. So they do a scientific poster where they research a health problem in their community and then reflect on how social determinants of health impact that. And then we do some hands-on skills to keep them engaged so they don't get bored in their Wednesday evenings. So things like casting and suturing, we dissect a heart. We do point of care ultrasound. We want to get their hands dirty in doing this. In the second semester, we bring them back and we put them in our clinic. So we get them CPR and first aid trained, and then they spend time with our residents in clinic seeing patients. So they can see what it's actually like to be a family physician and to hopefully continue to be inspired to want to do that kind of practice. We've now had 23 kids come through this program. And really excited to continue to do this. Our last session was last week for our fall session for this year. So we reach out to high school students across Flagstaffs in a lot of different ways to try to connect to high school kids, because it turns out they are not easy to find without looking creepy. So we go to a lot of high schools, we talk to their counselors, we reach out to clubs, we have social media, we have flyers to engage them. Many ways that we try to find high school kids in our community who might otherwise not have similar opportunities for mentorship as they move through their careers right now. So as I mentioned, it's a 9-week session with these kind of interactive, engaging opportunities that are led by the residents. It's important for us that this is resident-led, not just because we're a residency and we want to engage them, because the residents are closer in experience to the high school kids than, say, I am, who've been out of high school for far too long. So the residents can connect in a way that is harder for me to do as an attending, and we want them to build that connection so they can truly have a mentorship relationship. We already talked about that. So the residents, all of our residents have been involved at some point, and most of us have never been taught how to teach anybody. So we do a lot of sessions with them about how to build a lesson plan, what kinds of things are you going to teach, how do you manage a classroom. There was one point where we had 2 kids making out in a corner and we had to be like, oh no,
That's not a part of this. So helping the residents learn how to do that kind of teaching, which supports them in their clinical practice as well, because it helps keep them engaged in the community and really understanding what's happening out in the world, not just for the care they provide our adolescents, but for all folks that we are providing care for. Our students, we have had 23 students that participate in this program. 46% of them, excuse me, will be first generation college students. 80% would be identified as underrepresented in medicine. And just this year, we had 3 apply to an accelerated med school program out of our participants. So very, very excited. Fingers crossed they get in. We'll find out next month. So 85% said they very much enjoyed this healthcare activity and that increased their knowledge of health professions, careers. And 100% said they would recommend this to other students. This year, in fact, we had students from last year's session who reached out and said, can I do more? Can we do it again? And we're like, well, it's literally the same thing. So I mean, you could do it if you want to. And they created themselves their own program. So our students who did last year's program and wanted to come back functioned as additional mentors for our current programs. So they helped design our lessons. They worked with our residents. They helped support their peers in those programs. So it's become kind of a self-fulfilling prophecy to keep students interested in moving forward. We've been very fortunate to see that interest in healthcare careers and feeling like they understand what the next steps and pathways are in their training improve after participation in this program. And students enjoy it. They enjoy coming to hang out with our residents. Students talk about how it inspired them to continue into health careers, that folks who had never considered rural medicine before were now interested in a rural career practice. And that they felt like this gave them a really good opportunity to get hands-on while exploring other opportunities they hadn't considered before. They also are eligible for a scholarship if they complete this program, which money helps. So students who complete this program and do all 9 of the sessions are eligible for a $3,500 scholarship to support their undergraduate career, interesting in hopefully a health profession program. So far we've had 10 scholarships awarded. So the program, if you're interested in doing a similar program somewhere else, is not too expensive to run, as long as you're willing to donate your time. That's where the cost is. But the actual cost of supplies is about $2,000 per year to run. This includes supplies for simulations, like if you want to buy dissection materials. I'm pretty sure I'm on an interesting watch list right now. I order a lot of organs on Amazon. Poster presentation supplies, printing materials, and then we give them meals and snacks to keep them engaged. All about $2,000 for the entire year. The time commitment's about 2 hours per week for each session. And then for the staff, myself and our staff person who work on it, it's about 2 to 3 hours of preparation, cleanup, and setup. So this isn't, as I mentioned, directly about behavioral health, but certainly we're interested in supporting behavioral health care careers as well. So it's possible that you could switch your curriculum around to be a more behavioral health focused curriculum and less in family medicine. So potentially a careers workshop and panel that includes behavioral health clinicians instead of family medicine doctors. Skills workshops that might be interested in a behavioral health career. Critical thinking and problem solving is important for all of our careers. We want to really reinforce the role of social drivers of health, encourage health professions exploration, including behavioral health. And we know primary care provides a lot of behavioral health care in our communities. And then to connect students with mentors. So my question for you is, what could be done different? How could we do this in a behavioral health sphere with a similar model? So thoughts, what do you think could be done differently to really harness in the behavioral health focus? I also have a slide of my own ideas, but y'all probably have better ones. Absolutely. Youth peer support would be an excellent, I think, way to adapt into this. Absolutely. So both connecting, right? We used to think of physical and mental health as 2 different things, which is of course nonsense. So trying to draw those connections for folks, I think is an excellent idea as well. Any other thoughts? Yeah, I can repeat if you would like. Yeah, there's no reason they have to be mutually exclusive, right? That this can be a shared experience for folks. That one was cool. Absolutely. Adding in traditional and cultural medicine, I think would be an excellent addition, particularly that's targeted to the communities or the populations that you are serving would be fantastic.
Absolutely. And I think this really does lend itself well for an interprofessional model, either in this kind of model itself that utilizes interprofessional team members to do teaching and mentoring within a single model, or to have different professions do this themselves. Like you could totally do a social work version of this. That would be excellent, I think. So I really like it that it's very adaptable and it's very something that you can put into your practice in whatever community or setting that you're in. So here are my ideas. You could teach mental health first aid training, skills workshops like motivational interviewing, understanding bias and cultural humility, crisis communication basics. You could dissect a brain. I think dissecting something is critical. You got to get them to like, it needs to smell bad. You could talk about psychiatric disorders, intro to brain and behavior, stress management, stigma, advocacy and peer support strategies. Just the role of public health and mental wellness, I think would all be possible. You could have a career panel featuring behavioral health careers. Talk about educational pathways specific towards behavioral health careers. So how do you pay to be all of these various types of health professionals that we all are? You could focus their research project on mental health topics. So of our 9 students in this semester, half of them chose a mental health topic on their own as the topic they presented on. And then instead of shadowing me, they can shadow all of you. They can spend time in your practices. So I'm running out of time, but some barriers to implementing this thing, of course, is all the usual barriers: time, money, getting folks interested in doing this kind of work. It's always hard to ask people to do more, but I will promise once they do it, it's very fun. And people want to keep back in doing it. Our residents, this is a volunteer event for our residents, and 100% of our residents every year participate in this program. It can increase some discomfort for folks because we might be talking about sensitive subjects or areas that have a lot of stigma. So preparing your teams on how to address those is really important. And then obviously there's just a shortage of y'all. So we're asking you to do more things, but this is something that you could consider. And then you need a champion to support this kind of program. It's cheap, which is nice. Cheap is good. And if you have good stakeholders who are interested, it's very feasible to do in a multi-organizational or a multi-professional setting. And then there is money out there. So this particular presentation, not presentation, our program is funded by the Direct Relief Grant. So there are fundings out there that you can find to help support this kind of work. So our goal is to continue to expand this program, to scale it to other areas, to share our successes out, and then to talk about challenges that we have had, and then to explore opportunities to help support other organizations who might be interested in doing something similar. So I'm happy to answer any questions, or if at any point you want to reach out to me to talk about our program, please feel free to do so. We're very proud of it and very pleased to get to share the work that we are doing. And with that, I'll turn it back over.
So great. Thanks so much, Dr. Coles. And if you want to have a seat on our one-person panel, we welcome you. And I'm not sure if Dr. Pardee is still on the line. Nick, are you able to confirm that? She just stepped off. Okay. Okay, well, that was my mistake. So I'm sorry. If you all have particular questions for Dr. Pardee, I think if you submit them using that QR code, we can try to follow up with you afterwards. So any questions from the audience for Dr. Coles before I launch into our prepared questions? I mean, I have one that's totally off script. Like, what kind of organs can you order on Amazon? So many. Wow. I am so nervous.
I will share a funny story, but at one point I bought a bucket of rice. And they come in a bucket, and it was supposed to be delivered to my house and wasn't delivered. So I called Amazon and they're like, yes, it was delivered. And I thought, oh no, someone has something at their house that is going to be very upsetting. Sheep brains. Sheep brains, pig hearts, cow eyes.
Oh, I feel so much better. I thought they were human body parts.
Not human. What?
Okay. Wow. Wow. I feel so relieved.
I don't know where that bucket is. Someone's house has a bucket of brains. Good luck to them. Okay, sorry for that diversion, but thank you for not today.
Gosh, Dr. Cole's orders human body parts.
Like really bringing back the like 1880s gravedigger. Yeah, full Frankenstein on this.
We probably shouldn't be talking about this because these are our behavioral health folks in the audience, but sorry if that just traumatized anyone. So how about a few relevant questions? And we kind of got to this earlier, but this is a slightly different question. How do you think behavioral health and primary care prep programs might collaborate to develop some kind of a pathway for more integrated workforce type thing?
Yeah, absolutely. And I'm a really big believer in primary care integrated behavioral health because that is necessary to meet the behavioral health needs of our community and something that is well within the scope of family physicians and primary care. So in terms of, let's say, like higher level, so graduate medical education pathway programs, building collaborative programs like the psychiatry and family medicine residency in parallel and partnership to train each other to support each other's work so that you can do integrated behavioral health, you know when to refer, you know how to consult. If you are the consultant, you know how to be in that role to support your primary care provider, I think is really important. And then for earlier pathway programs like high school or grade school programs, I think integrated approaches like you mentioned earlier of, your body and your brain are not two different things, and that we should treat them simultaneously and understand how our behaviors, how our mental health and our physical health are all integrated is, I think, a very doable thing to do in our programs. There's no reason you can't be dissecting a heart and talking about motivational interviewing, about how do you create change? How do you support people when they are struggling? How do you help people who are not ready for change and might need just some harm reduction strategies or other strategies throughout their kind of experience of whatever their health process is? These easily could be done together. And I think students are really interested in that kind of work. They want to support their communities. Many of our high school students go home and are like, I told this to my mom. Well, and you're like, okay, did your mom appreciate that? But they want to get involved and they want to help support their communities. And so giving them the skills to do so, I think makes a lot of sense.
Great.
I'm just curious how new this is for these kids. Like, especially, some like social determinants of health. And it sounds like they might be living it.
Yeah, it's variable. I think some of them have a concept. All of them have experienced it, right? Like all of us have experienced social determinants of health and how that impacts our health outcomes. But I don't know that they've always connected the dots, or that these are things that can be intervened upon, and that health systems and health professionals can act to improve social drivers of health, and that should they wish to explore a health professional career, this is an area that they can make an impact. So this is why we make them do a research project and then try to connect that specifically. Almost all of them pick a condition that has impacted them in some way. Either they have experienced, or a family member has experienced, or a friend has experienced, and then asking them to reflect on and to do research on how does policy and regulation impact this? How do our social drivers of health impact this? I think is really eye-opening for a lot of them. Part of their project we asked them to do is, what would you do to change this? What steps could you take now as a high school student or in the future to impact that social determinant and to improve that health outcome? And they get really creative and really thoughtful in those answers. And so we're hoping to inspire them to then go do it. Like, great, take that next step and go figure out how we might implement that.
Great. Any other questions from the audience for that?
Sorry. How did you come up with this program?
I don't know. Prior to moving to Flagstaff, I was working in Phoenix and I did a very similar program for middle school kids. That was a semesters long after school club program for them. And so when I moved here, it was really important to me to continue to have some kind of school-based program, because trying to get to students when they're in college
or already in a health professions pathway, it's really hard then to convince them they want to do primary care. So we're trying to get to them earlier. And then we talked with high school kids and just folks in our community about what do we think would be engaging, what would help to support our high school counselors, how can we really build on programs that already exist. And then we just kind of hodgepodged it together until we found something that seemed to work for us.
Well, thank you. I love it. I love the teaching, kind of circle that goes around. I love the community involvement, and I love getting these kids a pathway in. I can see a lot of different applications for this. So,
Oh, thank you.
I know it's a lot.
So much fun and
Yeah.
incredibly rewarding to get to
Good.
do this work.
Hello again. I just wanted to double check on two things.
Yeah.
What times of the year are these kind of happening? And two, summertime is a very available time for them. Are you doing anything to connect them with already established programs like Indians into Medicine up in North Dakota or anything like that?
Yeah, so our current timeframes are very much geared around our convenience, which is maybe not ideal. But so it's September, October, November for the fall, and then the entirety of the spring semester, they sign up to spend time with us. Usually weekends or their half days or spring break or those kinds of things. We have not engaged with them in the summer because we're a residency and that's just a busy time for us because it's when the residents transition over and they graduate. And then we're starting our new residents. But it is obviously the most convenient time for the high school students to do it. And then we do, as a part of their health professions exploration, connect them to other programs that exist. So we do a survey of our students to ask what they are particularly interested in, and then find other resources for things they might want to do on the off season between future phases. So if they're interested in the like Indian Health Services programs that exist, or NAUs, or U of A or EASU's programs that exist, we try to find them other resources to help support them. And then we stay in contact with them as much as they would like. So they all have my phone number and email, and will call and ask me questions about scholarships or whatever is happening in their lives, all obviously with parental consent, to do this, just to try to support them as much as we can. But yeah, summer would be great. I'm just tired.
Great. And that actually leads into kind of a follow-up question. I'm curious, it sounds like you kind of do a warm handoff to some of the programs at the colleges and universities. I'm wondering if you see opportunities for a more solidified connection or level of support from us and others across the state who are working in the higher ed space.
Absolutely. And I will say that part of this is my fault for not knowing what programs are out there entirely. I've been here 3 years, so you feel like I should know at this point, but I don't completely. So yes, I think that the more connections that we can build in these kinds of pathways and support programs, the better, because there is a lot of opportunity for a warm handoff and to be like, we've gotten to this step, they might be interested in this next step. But like a menu or a catalog of existing programs, knowing who runs them and what services they offer and who is eligible are things that I don't know and would be very, very helpful.
Great. I bet we can get to something.
Yes, please.
Okay, that's wonderful. Thank you so much.
Thank you, everybody.
And for our very last, but definitely not least presentation, we have a speaker who traveled all the way from Texas this morning amidst some travel delays, here to talk about integrated behavioral health, which is a personal passion of mine because we've already alluded to the fact that physical and mental health are not separate entities. So we're very pleased to welcome Dr. Charla Burns. Dr. Charla Burns is an alumna of Louisiana State University and A&M College, where she earned a Bachelor of Science degree in biochemistry. She also holds a Doctor of Medicine degree from the UTMB School of Medicine. Dr. Burns completed an internship in internal medicine at Tulane University Medical Center and earned a diploma from the Campaign School at Yale. Well qualified in her field, she has extensive experience in public speaking on health-related topics at medical conferences and community events. Dr. Burns is currently an associate professor of neuropathophysiology at the Cummings Graduate Institute of Behavioral Health Studies and an adjunct faculty of anatomy and physiology at Prairie View A&M University. She is a life member of Alpha Kappa Alpha Sorority, an organization where she has proudly served for the past 27 years. Dedicated to civil advocacy, Dr. Burns serves as the treasurer of the board of directors for She Votes, a nonpartisan nonprofit organization that supports young women in becoming registered voters. Dr. Burns is also a life insurance broker and notary public in the community. Dr. Burns serves as a motivational speaker, political activist, and youth mentor. Please help me welcome Dr. Burns.
Thank you so much for having me. I am the last speaker, but hopefully not the least. I have traveled from Houston to be with you all today, so I'll just appreciate just a little bit of your attention. Okay, that is the first slide, I'm sorry. So I'm an associate professor at Cummings Graduate Institute of Behavioral Health Studies. My main focus is I'm a subject matter expert over the medical literacy department. So I bring in the medical piece to the physical piece. So that's how I'm integrated in that. So before we go into integrated care and say why it's so important in today's healthcare society, let me just tell you a little bit about the institute where I teach. So Cummings Graduate Institute for Behavioral Health Studies, it's a 501c3 nonprofit, private post-secondary institution offering graduate and professional behavioral health education through virtual online campus. So we are completely online, students online, teachers online. I have students all over the country and even outside of the country. That's why I love about this remote program. I love teaching here. We're licensed as a degree granting institution by the Arizona State Board for private post-secondary education. Our mission is to disrupt healthcare by preparing entrepreneurial integrated care professionals through innovative and affordable quality distance education programs grounded in the Biodyne model and focused on delivering human-centered care, population health improvements, and medical cost savings. So these are our values as an institute. We believe in accountability. We believe in entrepreneurship and innovation. We believe in impact. We believe people first. We believe in trust. We believe in partnership and collaboration. We believe in teamwork, and we believe in access and diversity. And one thing I really love about teaching at this institution is I have students from all different backgrounds. I have social workers, clinical licensed psychologists, behavioral health analysts. Some are in their 20s, some in their 30s, some are in their 40s. They've been out, they've gotten work experience, and now they're coming back to get a second, sometimes even third degree. So the degree programs we offer is the Doctor of Behavioral Health degree. But on top of that, we have stackable certificate programs that you can get along with the DBH. We have integrated behavioral health certificates for specialized populations such as the adult, gerontology, leadership, military families and veterans, and women's health. And we also have trauma-informed care certificate programs. And next week, I'm actually enrolling in the leadership specialty because I want to learn more about about integrated care as a primary care physician. So what is integrated care? So we talked about this a little bit when Dr. Coles came up here. You have the physical world and you have the mental world. They don't talk to each other. So I would agree that healthcare in America is very fragmented and a lot of patients fall through the crack because the right hand's not talking to the left. So integrated care refers to a healthcare approach that coordinates and collaborates between different healthcare providers, services, and organizations to provide comprehensive patient-centered care. So we have three arms. You have the person-centered. We always want to treat the patient with care and respect. We need to make sure we know their values, needs, and preferences. And also we want a patient that's a partner. We're not towering over them. We are authority figures, but we want to treat them like equals. That's how you form the best relationship. We also believe in evidence-based. So things that are rounded in research, clinical-based practices, and then also coordinated care. Or again, you have to have a seamless transition across providers, settings, and time, and meaningful and timely exchange. I don't know how many times I've had delays in having to request reports and records from other facilities, and it takes forever to get there. We need to have one centralized location where I know what you talked about with this doctor and this provider and this social work, so we can come together to find a common ground. Otherwise, patients fall through the cracks. So the key features of integrated care. So the first is collaboration. Healthcare professionals from various disciplines, such as primary care physicians, specialists, nurses, social workers, and pharmacists, they work together to provide seamless care. The second is patient-centered. The focus is on the individual patient's needs, preferences, and goals. The third is coordination of services. You want to have services that are coordinated across different healthcare settings, such as hospitals, clinics, and community-based organizations. The next is data sharing. Information about the patient's health status, treatment plans, and progress are shared among providers to ensure efficient care. Again, not having to dial for records and having to go somewhere else to get the information you need. And the last is continuity, right? The last thing you want to do once you build rapport with the patient is drop them off, okay? So we want continuity of care where care is provided consistently over time, regardless of where the patient receives treatment. So even though the patient may move to another location, they still may be able to consult me through telehealth and other remote services like that. So there are different models to support integrated care. So the first one is just coordinated. So that's the very minimal level. So this is where you have separate treatment plans and physical locations. Communication typically relies on traditional referrals and occasional information sharing. So I would see a patient, say, hey, you need to see a psychiatrist, refer them out, don't follow up with that, and then that's the end of it, okay? The second kind is co-located, where you have providers that are in the same facility, which improves referral processes and warm handoffs, but they may still operate with separate systems and limited joint planning. So now we're a little bit more friendly, right? We're still, getting together. And the last one is where you have fully integrated, where it's a seamless team-based approach where physical and mental health needs are treated in a unified way. There is shared responsibility, universal screening, and collaborative treatment planning, often supported by shared electronic health records. So there, within this, you have different models. I want to save this slide after I show a video where I would really think that you would understand what we really mean by integrated care. Come back to that as well. So this is a video. How do I play this, Nick? Where did he go? So I believe a picture is worth 1,000 words, but a video is even better, right? So she had everybody in one place. She had the nurse, the social worker, the pharmacist. Everybody was co-located in one place. So going back to those models I talked about, which one do you think that represents? That was in the video. Fully integrated. And one day, this is where I hope our healthcare will be at some point. I don't know what it's going to take to get there, but this is what we're striving for. I think it's kind of like going to Walmart, super Walmart. You can go grocery shopping. You can get your car looked at, some tires. You can get electronics. They got a nail shop in there, a bank. They got everything in there. So that's what integrated care means, right? So I feel, okay. Okay, so I love this diagram because it shows two hands shaking and you see all different colors, and that color represents diversity because that's what it's going to take, all of us working together. So the benefits of integrated health care include improved health outcomes and patient experience, reduced healthcare costs, enhanced access to care, lower risk of chronic disease complications, and increased patient satisfaction. How many patients do you know will be positively impacted if they don't have to go to 1 million different places? That would increase compliance, right? In summary, integrated care is a holistic healthcare approach that emphasizes collaboration, patient-centered care, and coordination of services to improve health outcomes and provide the best care for individuals. So, teamwork makes the dream work. We're better together. Takes a village to raise a child. It's going to take all of us to care for our patients. And that is the end. So thank you for your attention. If you want to connect with me, you can just scan the QR code, and that's my LinkedIn profile. I'm on it all the time. So. One person panel.
Thank you. Y'all are so brave today. That was really so great. And I know we couldn't hear the sound, but I loved reading it and I loved seeing it. I think it really does demonstrate what's possible in integrated care. And so want to open it up to questions if folks have them specific to integrated health models or integrated health and how it pertains to behavioral health workforce. Okay, I'll go ahead and launch into my questions. So from your perspective, which integrated healthcare competencies are most critical for new graduates, say coming out of a behavioral health prep program?
I think the main part of that is medical literacy. This mic isn't working on time. Oh, okay. So one of the reasons they hired me at the institution where I work at is I'm the only MD on staff. Everyone is either a doctor of behavioral health, a psychologist, or a doctor of education. So I bring in that piece of scientific knowledge because that's what they're lacking. So when they go to have to interact with primary care physicians like Dr. Coles, they don't have that basic science knowledge to understand terminology, and so they're lost. So what they're doing now is they're integrating a lot of medical literacy courses into the curriculum because, again, some of these students have not seen the inside of a classroom in 20, 30 years. So they lack that basic knowledge. So when they go on rounds with other healthcare professionals, they're lost. So we're trying to get them to talk more so they can learn the lingo because they've been trained to do, psychoanalysis, motivational interviewing, CBT, all those things are good, but then they don't know the anatomy. They don't know the lingo that, doctors like her would speak, and they're lost. So that's a big piece of it.
Yeah, that's a really great point. And I think that came up actually before in one of our behavioral health advisory committee meetings.
Mm-hmm.
And I'm wondering, are there particular physiological disorders that might show up or manifest as a mental health disorder?
Like dementia.
Yeah, or even how does diabetes affect mood?
Right.
What are some of the physiological underpinnings or disorders that folks who are getting trained in a behavioral health field might really want to learn more about on their journey?
I think as a behavioral health professional, you need to make sure you rule out the organic causes first, because diabetes, thyroid disorder, those things can cause you to kind of act wonky, and they want to, attribute it to something else, but you got to make sure, that you check all of those things before you attribute it to mental illness, because nobody wants to deal with the stigma of mental illness. And you want to make sure it's something treatable with, insulin or thyroid medication. Sometimes anemic patients present as depressed. And so they want to diagnose you as being clinically depressed, but you're tired all the time because you have low blood cells. So those things really need to be checked before you diagnose somebody with a mental disorder.
Mm-hmm. Great.
Yeah.
Great points. How might behavioral health and primary care programs collaborate to develop a more integrated workforce pipeline?
Everything she said. Presentation.
Okay. Okay. What Dr. Cole said.
Yep.
And how do you think the Cummings Graduate Institute certificate model might be adapted or replicated in Arizona, the certificate in integrated behavioral health?
We're located in Arizona.
So can you talk to us about how that's available to students currently, and what are some of the qualifiers that might allow them to get that certificate?
Oh, it's those classes are taken along with the DBH program at our university. So they're stackable credentials. So if they're enrolled in the DBH program, they can take any of those programs. But as a faculty member, I can take them as well because I teach there, even though I'm not a behavioral health professional. But they're stackable credentials as long as they're enrolled in the program.
Great.
And everybody's online. So we accept students from all states. Don't have to be in Arizona. There are certain, it depends. It's on a case-by-case basis. If you have a legitimate reason for wanting to take the certificate program, they'll let you do it. It's adapted from ASU, yes. They have modified it now.
And I'm going to just repeat Brooke's question in a simpler fashion for the folks on Zoom. Brooke was asking about any existing models within Arizona of success of truly integrated health, because there seem to be a lot of barriers in the state and kind of a lack of buy-in.
That part, I live in Texas, so Arizona I'm not quite as familiar with, but I know in Texas a lot of the barriers are financial, and then also policy dynamics that come from the government. So those are usually the things that hinder that from progressing. Yes.
Can you?
I've not got everything. There are successful models in Arizona, the most commonly used model is collaborative care model, or COCM model. This model is successful because it allows for communication across different healthcare institutions.
Thank you. So the collaborative care model is the model that I recommend that has been successfully integrated into health systems. But the reason that I think it's successful is because it gets paid. So you can bill for that type of care, which is really important for it to actually succeed. So the collaborative care model has the primary care physician doing the bulk of the mental health care with a consultative psychiatrist and a care coordinator or navigator who helps to track the patient to make sure that we're treating to a target, like working towards specific achievable goals. And then you bill based on time, like how much time the three of those folks together are putting into, and then insurance companies pay for it so that you can actually, employ people to do this work. The collaborative care model is successful integrated it. And it costs very little. There's a startup cost. You got to pay folks to do that. But for every dollar you put, save $6 ultimately the assisted patient. And has the largest evidence bases in terms of improvement for outcomes.
How is that? Is that
Yes, it is more difficult. And so I will tell you that the psychiatry residency and family medicine residency are building a collaborative care model. So this is something that we are working on right now to do it in a setting. Sorry, I don't have a lot of opinions.
I like that because we've been model. A lot of places are pushing type of thing, like the government agencies, healthcare delivery system is trying to do that for the last 15 years and successful. So it's like it's a different approach to it. Now, like, if it's successful, it's easy.
Yeah. So there's less stigma, you don't have to go somewhere else, and then you still get that expertise from all of you.
Thank you.
Anytime.
Hi, so much for being here. The question for you is, curious to hear your thoughts, opinions, if you know cases or successful models based off of the direction of the integration. And what I'm talking about that is looking at the established primary care family practice, and now we're integrating to that versus the established behavioral health practice, and now we're integrating primary care there. Just thoughts or comments on that?
One thing first.
Yeah. Same.
Again,
Both strategies have been done. And successfully. So like Bayless Health in Phoenix has done that.
Banner Health did it the other way. So you can do either way. I know that the Ryan Center has done some strategies of behavioral health with integrated some primary care. North Country has done, there's primary care and integrated behavioral health. So it can be whatever direction that your organization and your community needs.
Dr. Gibson standing up. That's good.
Yeah, just say that. Just struck. I live in the telehealth world, and so I'm struck by the integration of there's a true chance to get shuffled around the state, and the values change based on especially having kids and with adults who are disabled or who care. So when you're a kid, you can to go to residential treatment. And then Tucson, because of course there's no treatment facility that you can, they end up in Tucson, and then
psychiatrists, the therapists, and my family can't afford to go to some of those telemedicine. So team follows the patient instead of the patient to the team. And so it's just the backside of the coin.
I like.
Yeah. We just do our best, right?
Thank you for that, but that's a really great point to think about, co-location. I always think about that requires the physicality and the shared space, but maybe we also think about online. Love that. Are there other questions? I have one more, if not. Okay, so I want to end with, how does integrated healthcare help to reduce disparities in access to mental health care for underserved populations?
Wait, repeat that question.
How does integrated healthcare help reduce disparities in access to mental health care for those from underserved populations?
I think part of it, like the telehealth part, we come to them. So if you can't get to the clinic, you got the internet, you can do that. You're doing everything in one place. And then a lot of people that have mental disorders, they don't want to go out into the world. They feel like people are looking at them. So when they can go to one place that does everything that they need done, they're more likely to, take their medication, to come to counseling, to see their doctor, to see their social work. So it's taking the stigma out of everything. Because I again, if you have diabetes, oh, okay, that's fine. But if you have ADHD, people look at you for it. But it's a disease just like diabetes. Again, it's the stigma of having something mental that people want to label you as crazy. So I feel like having everything in one place, having access to services that are easily locatable, and then the telehealth portion for those that don't have money to drive across town, to see their physician, to go to the pharmacist to pick up their medication, to go to the dentist to go get their dental care. You're putting it all in access for them in one place. At least that's the goal. That's what we're trying to go. So.
Okay, with that, let's thank Dr. Byrne. Thank you so much. What a great lineup of speakers. And I just want to give one little selfless plug because we were talking about integrated care. If you are an employee at NAU, you may or may not know that there's an integrated care service right here on campus. It's called Campus Health Services. And I would say, are almost fully integrated. We do share an electronic health record for students so that we have mental and physical health all in one place. We have mental health and physical health providers all in one place. We also have embedded behavioral health care providers who are there to accept warm handoffs from providers. We do universal screening for substance misuse and depression and intimate partner violence and other things. So I'm just gonna brag a little because I'm really proud to work in such an innovative area. And I would just invite you, if you're in the academic preparatory side of the house, to think about how we might partner with you all if we're wanting to graduate some folks who are more well prepared to work in those integrated settings. There maybe is a training space right here on campus that could be utilized even more than it already is. So now, the fun part, the survey. we really would love for you all to give us your feedback. It's a pretty quick survey that Natalie developed for us. And I believe it is a requirement for CEUs. And I think Nick can tell us a little bit more about CEUs. And after we do the survey, we do have a little bit of time built in for networking because it was kind of a fast and furious day. So we have tables designated for each of our topics, and we would ask our speakers to just sort of mill around and find where your table is. And then that way folks can kind of come and introduce them, maybe introduce themselves to you, make a personal connection, and explore future collaborations.
Just wanted to say thank you all again for being here. Thanks again to our speakers for all your hard work. I think this has been a 3-month process that we've been working on. But in order to receive your CEUs, you will need to do the survey in its entirety. And so I think the last question on there is your like your medical ID in order to receive those credits. If you do not have that today, shoot me an email and I can get you this link either later today, tomorrow, or next week. But yeah, please let us know how we did. I know we had a couple hiccups today, but thank you so much for your patience. And we do have some great workshops coming up. I believe all of them except our UMA are virtual. And so we do try to keep these hybrid just so you can participate at your home. But thanks again for coming. And yeah, have a great time networking and hopefully you'll walk away with this workshop with something great.
And can we just give one final round of applause for Nick, who saved the day? It is totally awesome. So thanks again so much for taking time out of your busy schedules to be here. We so appreciate you. Hope to partner and collaborate in the future. And feel free to stick around for networking. Thanks, everyone.